part of being a pediatrician. It's 3 years of wonderful learning with experience and exposure to teachers who are able to give their wisdom and pass on their knowledge and skills to us. I say this because after you finish a post graduation, very difficult to get back in touch with the teachers, and very rarely do we become students again. But IAP Twin Cities branch has decided that this year onwards we'll have postgraduate clinics every month, wherein we go through a case in detail, understand the fine nuances of clinical examination, decision making, and also management. And I thank on behalf of my executive board all the participants who have joined us here today. And I request our president, Dr. Sunkoj Bhaskar sir, to please give his inaugural remarks. Bhaskar sir.
Yeah, thank you, Dr. RSV. Am I audible properly?
Yes, sir. Please go ahead.
Yeah, good morning and welcome you all for this first Iaptcb PG clinics in 2020. As we had committed in our presidential action plan, we are doing symposium, Iaptcb clinical meet, Iaptcb PG clinics, and as well one physical CME. This month, January, we did first symposium on pediatric genetics, which was attended by the luminaries of the pediatric genetics in the country, particularly the faculty I'm talking. Then we had Iaptcb clinical meeting at Neelofar Hospital, which was attended by around 85 postgraduate students at Neelofar Iaptcb Neelofar Auditorium. And we had released our Iaptcb first journal during that installation ceremony, which we had on 6th January, I believe. And this is the first PG clinics we are doing. And now I remember we had one PG clinics last year, a physical one done at Lotus in 2020, wherein the expert was Dr. G.V.S. Subramaniam. It was attended by around 100 postgraduate students, and the auditorium was full with the postgraduate students. So that enthusiasm and zeal is still there among our PGs. That's the reason why this year our thrust is mainly for postgraduate students and as well practicing pediatricians. So at the outset, my profuse thanks to Dr. S. Narasimha Rao for accepting as an expert and a lead discussant for this Iaptcb PG clinics. As you all know, after his residency of MD Pediatrics, he moved to his native place, Kottagudem, and they started doing practice there. But as a zeal and thrust he has towards academics, he moved back to Neelofar, and from then onwards until today, he is very actively involved in academics, and we all remember for his astute clinical skills, for his ward rounds, undergraduate and postgraduate teachings, and particularly his research activities and contribution to thiamine-related issues, particularly encephalopathy and wet beriberi. I'm glad that we are associated with him at Paramita. If we have any complex cases, we seek his advice and he obliges. Thank you, Dr. Narasimha Rao, and I'm happy to share one more thing, that I am his contemporary during our undergraduate studies. Thank you, Dr. Narasimha Rao, for accepting and coming to here as an expert and lead discussant. And my profuse thanks to Dr. Aparna, being slightly indisposed, still she has come forward to be here again as an expert and lead discussant. It shows her zeal and interest to spread the academic skills and academic knowledge. One interesting thing about her is, some of us know that she stood seventh. She stood seventh in common PG entrance examination of then Andhra Pradesh. That's only a tip of the iceberg of our academic talent. Thank you, Dr. Aparna, for allotting this interesting case from Neelofar. Though the Iaptcb PG clinic's name suggests that it's mainly meant for postgraduate students, but honestly, it's for postgraduate students, for practicing pediatricians, for all the clinicians caring for children, because this is the base, as our elders tell always, that our proper history, proper physical examination will take us to the almost to the diagnosis of the case. Probably around 90%, probably we will be right if we take history properly and approach to the case properly. So the main intention of these PG clinics is to how to approach to a case and how to come to a differential diagnosis, but not to the final diagnosis. That's not very important. Lastly, the most beneficiary of this entire PG clinics would be none other than Dr. Aditya, the presenter of the case today, because it's going to be a real experience for him, and it is similar to his long case in his upcoming final exams of his post-graduation. I request all the PGs and IAP members to participate in a big number to encourage us in our future Iaptcb activities. So thank you all once again. There are seniors for whom I pay my respects, particularly Dr. Ram Narasimha and others. And long live IAP. Jai Hind. Over to Dr. RSV.
Thank you, President, sir. Welcome, Dr. Narasimha Rao, sir. He's just joined us and he's a co-host. And we also have Dr. Aparna as the co-host and Dr. Aditya as the co-host. And the co-host will be able to mute, unmute, and also share their screen. I request all the participants to please use the chat box and share your thoughts. Please, if there are any queries, any of your insights, please continue to use the chat box and share it. And towards the end, we'll definitely make sure we unmute everyone and we'll be able to interact freely towards the end. At the outset, it will be a interesting case discussion between the presenter and the two experts, and we'll definitely have comments pouring in from all the audience and answers given by the experts on this as well. I now hand it over to Dr. Aditya and also Dr. Aparna and Dr. Narasimha Rao, sir. Over to you three.
Good morning. First of all, my apologies. Somehow I couldn't get connected promptly and there was a little delay. And I'm apologetic about that. And I'm extremely thankful to the organizers, particularly Bhaskar and also Sri Krishna, for giving me this privilege to be amongst you and share a little bit of wisdom and knowledge which I have accumulated over a period of 3 to 4 decades. And I'm sure I will not be disappointing them and disappointing the audience. And I am also thrilled to have my co-discussant, Dr. Aparna, whom I have seen right from her PG selection. And she is also a wonderful lady. And she has got a very good academic flair. And she is the one who actually first presented the a series of 7 cases of thiamine producing Lake syndrome like symptoms, and I was really thankful. Only after her presentation, I got too much of interest and really took to the that enigmatous disease to its final conclusion. And I know Academy of Pediatrics Twin Cities branch is doing excellent work. And I have seen Bhaskar while he was secretary. He has taken our Twin Cities branch to a different pinnacle. And he is the one person who has really saw that we procure land in a prime area, and hopefully during his presidentship he will take it further. And I'm thankful. Ram Narasimha Reddy is here. He is my senior. And there are other senior people. Hopefully, all of them will interact and give their feedback and also inputs. And I'll ask Aparna, my co-panelist, to tell a couple of words.
Sir, at the outside, I want to thank Dr. Narasimha Rao sir, Dr. Bhaskar and Dr. Sri Krishna for giving me this opportunity. Dr. Narasimha Rao sir, our professor, he has always been encouraging me from the beginning. So I just want to thank for giving me this opportunity, sir. We'll go about with the case.
Aditya, it is all yours now.
Yes, sir.
I will like to ask Reddy, Narasimha Reddy, you have anything to tell?
Please unmute. Dr. Ramanaswamy, unmute. Dr. Ramanaswamy.
Okay, we are not able to hear him.
Please unmute. He's not unmuting.
Hello.
Yeah, audible now. Please, go ahead.
Glad to see Narasimha Rao. We were colleagues also at the same time.
Yeah.
Anyhow, you continue. Just I will end. I will tell you what is basic difference between a history taking and a physical examination. Go ahead.
Okay, thank you. Thank you.
Thank you.
Go ahead.
Good morning, everyone. I'm going to share my screen. A 16-month-old female child, resident of Hyderabad. Sir, am I audible, sir? Am I audible, sir?
Yeah, very much.
Yes, sir. Thank you. A 16-month-old female child, resident of Hyderabad, brought to the hospital by her mother, good reliability, with chief complaints of inability to walk and sit since 2 months and swelling of the upper back since 5 days.
Move on.
The slide is not moving. I think there's some more technical issues. Child was apparently asymptomatic 2 months back. Then mother noticed that her child has difficulty walking, which progressed to inability to walk over 20 days duration, difficulty in getting up from sitting to standing position, difficulty to sit up from lying posture, and difficulty while turning in bed. Gradual onset and progressed over 20 days. It is not associated with any excessive cry or irritability. History of swelling over the upper back.
1 minute, you can stop.
Yes.
So what is the main complaint? Sir, can I ask, sir? Sir, can I ask him some question?
Yeah, yes, madam. Please go ahead.
See, what is the main complaint, Aditya?
Ma'am, the main complaint was the child, mother complained that the child is not able to walk, ma'am, initially. Child had initially difficulty walking. And then over a period of time, she stopped walking. And then child had difficulty while getting up from sitting position, from sitting to standing position. And also the axial weakness, posture, from lying down posture to sitting down position.
Okay, but what information you are getting from this history?
Here, yes, ma'am. Here, it implies that there is weakness of the axial muscle. There is a axial weakness and also lower limb weakness, ma'am. As such, upper limb weakness is not. There's no complaint of upper limb weakness, ma'am. Usage of hands and all.
So what else you would like to ask when they come with weakness now?
Ma'am, we'd like to ask the duration of presentation, ma'am. Initial presentation and how did it progress? Whether it is an acute onset or gradual progression?
Yeah, that you have given. You have already told about the onset and progression.
Yes,
and mainly you're telling the axial musculature is involved. What other muscles weakness? Then you have to ask for other muscle weakness. Whenever there is weakness, You should
Yes,
go with, if they come with a proximal weakness, you should ask for the distal weakness. If they're coming for distal, proximal, other muscle and in the bulbar muscle weakness.
Yes, ma'am.
So you complete the history there.
Yes, ma'am. We'll have to ask for facial muscle weakness also, ma'am, and any abnormal respiratory patterns because of respiratory muscle involvement.
So for distal muscle weakness, how will you ask?
Ma'am, for distal muscle weakness, we need to ask. For the upper limb usage of hands, ma'am. As this is a 16-month-old child, we can ask the handling of objects, grasping, and all. And for the lower limb, usually we ask for whether the child is able to put on slippers and whether if there is any slippery. If the child is able to walk with the slippers or not. If the child is able to wear the slippers or not. Wear and remove the slippers.
So in the history itself, you have to mention all those things. Okay. So it has to give, the history has to give us information which muscles are affected.
Yes.
Yes, you can continue.
No, one more thing, since Aparna has brought out, history is most important aspect of a case.
Yes.
Please remember that. I would always tell, are you able to hear me?
Yes, sir.
Yes, sir.
Most important aspect. There was a study in UK long ago in one of the top tertiary hospital. A cardiologist has made a study, and as our conclusions were, as she's a cardiologist, she is no more now, and 59% of the times your history and your physical examination is going to help you, and the remaining about 30 to 35%, it is your routine investigations like CBP, urine analysis, etc. And only in 5% of the times, your high-end gadgets are going to be helpful. And 5% of the cases, you won't be able to make the final diagnosis even after the postmortem. This is important. That is what is being emphasized by Aparna. Now you have brought out in detail of your initial first complaint.
Yes.
Do you know? You have to make a preliminary conclusion, but you don't. You are open. Once you have concluded, you are not putting a lid on that. Remember this. You are always resilient. You are always open, and you are dynamically thinking what is happening.
Yes.
And with your first present, symptom, and as Aparna has put it, do you think it is a proximal problem? Do you think it is a distal problem? That makes a lot of difference.
Yes.
Isn't it? Because peripheral nerve issues, they have a distal issues, distal weakness followed by proximal weakness.
Yes.
And if it is a myopathy and other issues, you have proximal problem. What is it you think here?
Sir, I am supposing it to be a proximal weakness, sir.
Yes, very good, excellent. What is it making you to think it's a proximal weakness?
Sir, as lower limbs are involved here, in lower limbs, the proximal weakness main symptom, sign will be inability to get up from the sitting to standing positions.
Very good, excellent. That is almost you are giving a picture as if there is a Gower sign positive.
Yes, sir.
You are giving such a detailed description, and we are really made to conclude that is it Gower sign?
Oh, no, sir.
Anyhow, we will keep our options open and then proceed on.
Child is not associated with any excessive cry or irritability. History of swelling on the upper back noticed by the mother. Incidentally, 5 days back.
What is it you want to convey by telling that he is not having excessive irritability nor crying?
Sir, any sensory abnormalities, paresthesias, pain sensations, excessive pain sensations and all?
I don't think paresthesias will really make them cry excessively. But more than that, root pains.
Yes, sir, root pains.
Okay, that's right. Proceed.
History of swelling over the upper back noticed by the mother incidentally 5 days back. The swelling was of lemon size with no progression, no local pain, no redness, no discharge, nor scars over the surface.
Okay.
History of weight loss, approximately 2 kgs noticed by the mother. No history of similar episodes of weakness before. No history of fever at onset or prior to the onset of weakness and evening rise of temperature. No history of seizures, ear discharge, altered sensorium, or any loss of consciousness. No history of cough. No history of loose stools, vomitings, and pain abdomen. No history of painful neck movements. Child is able to hold on to objects and feed on her own. Child is able to hold her neck normally and able to breathe normally. No history of altered behavior, sleep disturbances, or difficulty in speech or excessive laughing. Child is able to recognize faces. No history of early hand preference. No history of drooping of eyelids or abnormal eye positions. No history of difficulty in chewing or mixing of food in mouth. No history of history of any auditory disturbances. No history of deviation of mouth. No history of difficulty in swallowing, nasal regurgitation, or change in voice. No history of difficulty in turning from side to side. No history of difficulty in changing diapers, slippage from the hands of mother, or abnormal posture of any limbs. No history of scissoring of limbs. No history of diurnal variations in the weakness. No history of abnormal sweating, urinary retention, or constipation. No history of any involuntary movements. No history of any fasciculations. No history of ability to perceive pain and temperature sensations. No history of nodding movements of head or intentional tremors. No history such of raised ICT. No history of bed sores or any other complications. No trauma history. No history of skin lesions. No history such of any congenital malformations. No history of abnormal behavior, TB contact, recent vaccination and dog bite. No history of ingestion of honey or canned foods. No history of exposure to heavy metals. No history of intramuscular injections in the recent past. No history of respiratory distress, abdominal distension, or any precordial activity or cyanosis, increased precordial activity or cyanosis.
So excellent. You have presented all the symptoms, negative history, and also the etiological history. But one thing I want to suggest is it should be in an orderly fashion, systematic. So here mainly he's coming with weakness, CNS symptoms. You are able to hear me, Aditya?
Yes, ma'am. Yes, ma'am.
So first you have to ask detail about the weakness, which we have already discussed, whether it is proximal, distal, or both proximal, distal, etc., bulbar also.
Yes,
then you go about with the other CNS symptoms like cranial nerve symptoms, other motor symptoms, sensory symptoms, cerebellar, ANS, extrapyramidal, and bowel bladder symptoms. Then you go to other system, any skull and spine also. Then you go to other system, like other systems involved. Can other system cause CNS symptoms?
Yes, ma'am.
So respiratory, GIT, so those symptoms you will ask. Then you go to the etiological history. So you have to club this history, because in between you are writing one etiological history, then you are going back to the CNS symptom. Not like that. It has to be in an orderly fashion.
Okay.
So whoever is listening to the history, they should get a clear picture. But you have asked everything. You have not missed out anything. But only thing is you arrange it in a systematic way.
Okay.
Okay. Sir, anything you want to tell, sir?
I think no. You know it is quite an elaborate history, and it is typically I think in the textbook description. I appreciate him, but the point I want to tell you after this, what is it you have concluded? Do you think there is a cerebral involvement or encephalon involvement?
Sir, there is no history of any abnormal, any altered sensorium, seizures, or fever. So I want to rule out cerebral involvement, sir.
Altered sensorium.
Sir.
You are told very unlikely. Supposing if there is a supratumor, what you call, infratentorial and supratentorial. If you have a supratentorial problem, what is it? The first symptoms will be.
Sir, if it is a supratentorial tumor, sir, we'll have to look for raised ICT signs and also.
Hold on. Now I am asking supratentorial. What would be the initial symptomatology? No. First of all, you have to tell me whether supratentorial tumors or space occupying lesions, do they present with motor deficits? Yes or no?
Yes, sir.
Yes, very good. Excellent. Yes. The second point comes is, what is the initial symptomatology in the chronology? If it is supratentorial, I'm not asking infratentorial.
Yes. Sir, the child irritability, sir, irritability, and then the child might present with seizures and then vomitings, raised ICT signs later.
What do you mean by irritability? Because these are all words under which we hide our ignorance. What do you mean by irritability? Can you elaborate on that?
Sir, yes, sir.
I'm sorry, because these are some of the words which encompasses many things, and we hide under that word.
Yes, sir. Sir, irritability here, it might be because of headache, sir, which the child may not express as a child is a 16-year-old child.
Now, second point is headache. What is the cause of headache in a supratentorial tumors? Because
Sir,
you know, brain parenchyma is not pain sensitive.
Sir, it is because of a stretching of the meningeal layer, sir, and also the vessels, stretching of the dura mater. I mean, dura mater.
Provided if it is abetting, provided it is abetting the meninges. If it is deep inside, obviously not.
Yes.
So that means the headache is not a consistent feature.
Yes. Sorry, sir, I did not get this. I did not get. I couldn't get.
Sorry, I'm sorry. I'll tell you again. Since headache is not a consistent feature of supratentorial tumors, as you yourself have told, because unless it is averting and causing the stretch of meninges, which are pain sensitive.
Yes, sir.
Can you tell me what else is the pain sensitive in intracranial portion?
Cerebral mass is pain sensitive, sir.
Cerebral?
The cerebral tissue is pain sensitive.
Cerebral tissue is not pain sensitive. Remember, you know, parenchyma, if you look at the lung parenchyma is not pain sensitive. Pleura is a pain sensitive. You got the point. Similarly, cerebral matter is not pain sensitive. Results which are pain sensitive.
Sir, I meant the cerebral parenchyma doesn't take pain. It is not pain sensitive. I was confused.
I'm sorry. So please be clear. No, you have to respect our senior citizenship. Okay. Sometimes we may not be hearing appropriately. Okay. Well, okay. Don't. You are doing very well. You are doing very well. So second point is, so now you come. Now having agreed that the supratentorial problems can give rise to motor weaknesses. X. Now the question was, what is it? What is the symptom, earliest symptom? You told irritability, correct? I take the irritability, but irritability really means, okay, I take that point, irritability, you know, in one sense, but I would tell you it is the personality change in grown-ups.
Yes.
In a child like 15 years, no, this child, 15 months, isn't it? This
16
child,
months, sir. 16 months.
16-month child probably was playing very well, telling patacake and interacting with the parents, and has got a stranger phobia. That would change. That milieu will change.
Yes.
Okay, that is the one of the initial part of the presentation. When you look at, you know, in a later age group, SSP, the earliest symptom is change in the personality.
Yes.
If you look at gray matter degenerations, other degenerations, the first symptom will be change in the personalities, and if it is grown up, then there would be decrease in the scholastic performance as well.
Yes.
But not the raised intracranial tension. And then if it is aborting the parasagittal sinus, then they can present with paraplegias. And you know the common causes apart from the tumor, spacectomy lesions. For some reason, there may be, what you call thrombosis of the sagittal vein, isn't it? All that you know, cyanotic heart disease, particularly when they have gone into the dehydration, you would get that.
Yes.
Okay. So that is what the infotentorial, they present with the raised ICT.
Yes.
And you have mentioned a lot of symptoms concerning the brain stem.
Yes.
And you have mentioned they are not there.
Yes, sir.
They are not there, isn't it?
Yes, sir.
Okay, very good, very good. Go on. Aparna, you have anything to say?
No, sir. Ade koncham order. You have to put in order.
Yes, ma'am. Sure, ma'am.
Symptoms and etiological history. If you club them, no, it will give more clear idea.
Yes, ma'am. Okay.
Okay. Okay.
No significant past history. There's no history of TB contact or any bleeding manifestations in the past. Antenatal history. The child is a.
Why did you take bleeding manifestations?
Sir, a 16-month-old child might present with any hemophilias where spontaneous hematomas might be present anywhere. Though it is very rare, spinal hematomas might be present, or the child might present with any IC bleeds, chronic, subdural hemorrhages, subdural hematomas.
So you mean congenital coagulopathies you wanted to rule out?
Yes, sir. Yes.
Isn't it?
Yes,
And because of that swelling could be hematoma, could
Yes,
be
sir.
hematoma, isn't it?
Yes. Yes, sir. Yes, sir.
You are and do you think platelet and vascular disorders producing bleeding tendencies, will they produce hematoma?
Yes, sir.
Go slow. Don't be hurry. Don't be hurry. No, you have to remember this point. Okay, you have to remember this point. See, remember the vascular problems and platelet problems, they produce superficial bleeds like PTK, purpura, bleeding from gums, bleeding from the cracked, and also they can produce intracranial bleed.
Yes.
But the coagulative disorders producing intracranial bleed I have not had. Coagulative disorders, you are talking of congenital coagulative disorders, which producing intracranial bleed. But however, if there is an AV malformation, if there is a vasculitis, isn't it? They can produce.
Yes.
Isn't it?
Yes.
So anyhow, you have to, but more than that, is there any disease process which can produce a tumor-like thing and also produce, which you keep seeing at least one case in a month in Nilofer Hospital, can produce motor problem in the spinal cord, which has got a bleeding tendency. Am I clear? Am I clear?
Yes, sir.
Can you tell me a diseases which you keep seeing in an institution, at least 1 or 2 cases in a month, which presents with a bleeding manifestation, and also there could be a lesion in the spinal cord? I'm giving a hint, and they may present with fever as well. They may present with multiple swellings.
Sir, ADEM?
Oh, ADEM. Okay, why do you think ADEM will have bleeding manifestation? It is a post-infectious demyelinating disorder. We are talking of bleeding manifestation. You have brought out that.
Yes, sir.
Because
sir,
you have brought out that.
Yes, sir. Because ADM has a rare complication, which is hemorrhagic.
See, ADEM on extremely hemorrhagic leukoencephalomyelitis.
Yes, sir. Yes, sir. Yes,
hemorrhagic leukoencephalomyelitis is extreme rare. I have not come across. I don't know. You must have not. Have you come across? That is an extreme, rapidly downhill course, and it involves again encephalon.
Yes.
Yeah, isn't it? But that is not. No, I will tell you again. Multiple swellings and bleeding manifestations, and fever may be there, or sometimes they are toxic. They may have something going wrong in the spinal cord as well. And I'm giving, they may have hepatocellular. Now you have to tell the diagnosis. And you come across.
Yes, sir.
Okay. Now some hematological malignancies. Hematological malignancies, particularly AML, can present with infiltration into the spinal cord. Okay, and they may have small tumors here and there, chloromas.
Chloromas, yes, yes.
Isn't it?
Yes.
Okay, but more than that, sometimes even disseminated neuroblastomas can have multiple, the neuroblastomas are not uncommon in this age group. Isn't it? Isn't it?
Yes.
Okay, you can think of on those lines, but anyhow, you thought of congenital coagulopathy, and that's fine. Go ahead.
Antenatal history is a registered case. Mother is a registered case, had regular antenatal checkups, taken 2 doses of tetanus, and IFA prophylaxis was taken. Fetal movements are well perceived. No history suggests of any obstetric or medical illness in all the 3 trimesters. Natal history is full term, normal vaginal delivery, tried immediately after birth. The child is 2.5 kgs at the time of delivery. No history of any NICU admission. Family history, no history of similar complaints.
Hold on. You have very well brought out one thing, that fetal movements were very well perceived.
Yes.
And with that history, probably can you rule out some condition?
Sir, SMA can be ruled out, sir.
SME, okay.
SMA, spinal muscular atrophy.
You are talking of wording happens.
Yes, sir. Yes, sir. Wording up.
You are not talking of later onset, isn't it? Okay. Isn't it? You are talking of wording happens.
Yes, sir. Spinal muscular atrophy, sir.
Oh, yeah, that's right. Spinal muscular atrophy, wording Hoffman is one of the same presence in the infancy.
Yes, sir.
Okay. And anything else?
Sir, other causes of floppy infant, like no,
when you are thinking of floppy, you are talking about one condition where is anterior horn cells were involved. That is spinomuscular atrophy.
Yes, sir.
And it just come down.
Oh. So congenital GBS.
Congenital GBS. Okay. I'm not really sure about that. I'm not. Aparna, are you sure about that? Congenital GBS.
Congenital muscle disorders. You tell some muscle disorders.
Yes. Now and then muscle disorders, congenital myopathies.
Correct. Congenital myopathies. There are, when you are talking of congenital myopathies, you are talking of fiber type 1, type 2, or you may be talking about congenital muscular dystrophies. Remember, congenital muscular dystrophies, I'm not talking of Duchenne or Baker's. Okay?
Yes.
Right. So you are fairly well, you have excluded some of those conditions. Okay?
Yes.
Isn't it? Very good. Go ahead.
Family history, no history of similar complaints in the family, no history of bleeding disorders in the family, non-consanguineous marriage, first in birth order. Developmental history, the child attained all gross motor, fine motor, language and social milestones according to age. Gross motor neck holding at 3 months, rollover at 4 months, sitting with support by 6 months, without support at 8 months, standing without support by 12 months, and walks with support by 13 months. Fine motor, bidextrous.
If it is appropriate, you can just tell it is appropriate for age.
It is appropriate for age, ma'am. Okay. All the milestones are appropriate for age. Nutritional history, child had a deficit of 500 kilocalorie per day and 7 grams of protein per day deficit.
Hold on. This is not.
Do you think it is sufficient nutritional history for this case of weakness and both lower limb weakness, axial muscle weakness? Do you think this history is sufficient in nutrition?
Correct. No. What is it? No. So Aparna is asking a very pointed question. So, do you think this protein and calorie deficiency which you have mentioned can lead to those a neurological issue, or are there any nutritional issue which can?
Yes, sir. Sir, the child here is having calories and protein deficiency, so child is undernourished for sure. So with the nutritional deficiencies causing such a weakness, we can consider anemia, like vitamin B12 deficiencies causing SACD, which is rare though in pediatric age group.
Yes, yes.
Okay, that's right.
So you ask more detailed nutritional history. No?
Yes.
Because, as a pediatricians, we are, our arena is nutrition, infectious diseases. Much more, isn't it? Infections and the nutritional problem. And these days, because of the welfare programs by a government, and we have plenty of production in terms of calories and protein, now we are not seeing those extreme situations of kwashiorkor marasmus prakia. But what is our problem right now is the micronutrients. And micronutrients, right from, as Aparna has pointed out, right from B complexes. And anyhow, due emphasis was given to vitamin A, and now we are giving much more emphasis for the vitamin D. But we are not talking about B complexes. We are not talking about other trace elements like magnesium, like the zinc. And then we are not talking much about the vitamin E, because they are all as important as major nutrients. Okay, you got the point. So from now onwards, I'm emphasizing to all the postgraduates, please let's really look into what is the quality of the food they are consuming.
Yes.
Is it just a rice which is empty calories from the ration shop? Are they consuming more than that, like greeny vegetables, fruits, nuts, pulses, etc.? I'm not talking non-vegetarian. Okay, so make an emphasis on nutrition. Nutrition is very important, particularly for epigenetics. I would always tell most of the diseases which has got a bearing on epigenetics, if not genetics. Okay, please go ahead.
Immunization history, BCG scar is present. Socioeconomic history, they live in a pakka house, single room with 4 people with separate kitchen, filtered drinking water, good toilet and sewage disposable facilities, belongs to lower middle class according to modified Kuppaswamy class. General examination, child is lying on mother's lap, pallor is present, no icterus, cyanosis, clubbing, koilonychia or edema, no significant lymphadenopathy. Vital data, temperature was normal at the time of examination, pulse rate 92 per minute with regular rhythm, normal volume and other peripheral pulses are felt. Respiratory rate 24 per minute, blood pressure 90/50 and SpO2 is 97% at 2 ml. Head to toe examination, head size appears to be normal. No change in hair or loss of color of hair or loss of hair. Eyes, ear and nose normal on examination. Oral cavity is normal. No oral ulcers, chelosis or glossitis. No signs of any vitamin deficiencies. No dilated neck veins. Nails and skin are normal in appearance. No petic or purpura. No tuft of hair or dimple present over the spine. No neurocutaneous markers. Swelling over the dorsal spine is present.
What are the neurocutaneous markers you look for?
Ma'am, we need to look for ash leaf macules, ma'am.
You tell the condition also, which it will suggest, that neurocutaneous markers and the condition it suggests.
And tuberous sclerosis, ma'am.
What other neurocutaneous markers?
Cephaloid macules in NF neurofibromatosis.
Yes.
Shaw-Green patches, tuberous sclerosis.
Put-Weinstein, telangiectasia.
Yes.
Vascular malformations.
Telangiectasias, vascular malformations, in hemangiomas, and abnormal Mongolian spots, ma'am. More number of Mongolian spots, abnormal Mongolian spots, which
I am not sure about Mongolian spots, which would disappear by 1.5 years of age. Are they really? No, what is Mongolian spots due to? Do you think?
Sir,
do you think they have any vascular issue?
No, sir.
No, what is that?
Sir, Mongolian spots.
Because they disappear. They
Yes,
disappear after 1.5 year age and without any consequences.
Yes, sir. If they are present,
what is it due to? Where is the problem? It is the migration of melanin pigment from the deeper layer of epidermis. That is the problem, isn't it? It is nothing connected with the vasculitis or vascular problem.
Yes.
Okay. Now I would ask, Aparna, you please go ahead. I have one more question I will ask later.
Sir, how to this summary up to here, sir? Actually, we have gone off to the examination up to history. Even people are asking in the chat box, sir,
Okay. Okay.
to localize the lesion
Right,
by history. So history, what do you think, Aditya? From the history and up to here also you can take up to this general examination. What do you think it is?
Yes, ma'am. Coming from will come from ascending layer, ma'am. From the ascending from the cerebrum, there's no cerebral involvement because there's no irritability nor altered sensorium or encephalopathy or seizures. We can exclude cerebral causes, internal capsule causes, ma'am. And then we have given history of brainstem, no abnormal respiratory movements, no and also involuntary movement. Basal ganglia can be excluded, ma'am. Brainstem lesions. Brainstem lesions can be excluded, ma'am. So now we are left with the cervical from the spinal cord, and there's no cerebellar symptoms also, no abnormal head movements or eye movements noticed by the mother. So cerebellar lesions can also be ruled out. Now coming to the cervical involvement, there is no respiratory muscle involvement, sir. So we can be sure that C3, C4, C5 are not involved. And also the upper limbs movements are normal because the child is able to feed well, the child is feeding well, the child is able to lift her head above the normal, which excludes both the proximal and distal weakness of the upper limb. So the brachial plexus is excluded. So until C5.
So cervical lesion also is excluded because upper limb is not affected and
upper limb is not
respiratory,
yes, yes, ma'am. Respiratory muscles are also not involved. So it is clear that the lesion is not above T1, ma'am. So because the brachial plexus is not involved, nor there is any Horner syndrome or abnormal.
No, that we have not gone into the examination. Don't tell about Horner syndrome and all here. Only from the
yes, ma'am.
From the general examination, what do you think?
Yes, ma'am.
Okay.
Yes,
So now we are left
because there is no ptosis.
Weakness of both lower limbs.
Yes, ma'am. Yes, ma'am. Weakness of both lower limbs, and here we cannot.
Weakness is there or complete paralysis is there? Is it paraparesis or paraplegia?
It's complete weakness, ma'am. Paraplegia.
So still we have not done the CNS according to the mother only, symptom wise. So yes, complete movement is, so there is weakness. Okay, we can tell there is weakness of both the limbs, lower limbs. With one, you are telling there is a swelling over the dorsal spine. You have excluded lesions, central causes, brainstem, cerebellum, extrapyramidal, and cervical, upper cervical cord you have excluded. So the lesion, obvious swelling is there in the thoracic spine, dorsal spine.
Yes.
So that could be the cause. We'll see further what information we can get.
Yes, ma'am. One more point, ma'am. As there is a clear-cut swelling here in our case at the in the thoracic level, and as the child is a 16-month-old child, we cannot comment on the bladder and bowel because the child did not attain bladder control or bowel control yet. So, assuming as the mass is present, we are assuming and there are no sensory symptoms. As there no clear-cut sensory level,
we cannot tell clearly now. So yes, that is what I'm telling you. It is in the
thoracic spine level. It must be in the dorsal spine. Correlating
weakness
with the
of both lower limbs and due to a spinal cause, thoracic spine.
Yes, ma'am. Yes.
We can tell. So further from your examination, we will derive some more conclusions. Okay.
Yes,
okay. That swelling you are going to discuss here or later. Describe that
examination, ma'am.
You are going to give separately.
Yes, ma'am. After this, I'm going to give the systemic examination.
Okay.
Sir,
anything, sir?
Yeah, he was telling since a child is 16 months, because he will not be able to tell whether bladder and bowel involvement is there, isn't it? Isn't it?
Yes.
Now tell me, can he get spastic bladder? What is spastic bladder? What is spastic?
Yes. So spastic bladder is UMN, upper motor neuron lesion involving the sympathetic, sympathetic nerve supply to the bladder, sir. Where
now, can you just tell me now how the bladder is innervated? Once you are sure about this, then you would be able to tell it does not preclude
Yes.
Because of the age, they will not have bladder issues.
Sir, they can have bladder issues, sir, but we cannot. But what I meant was we cannot comment on incontinence of the bladder, sir. Whereas
Why you are only telling there can be a overflow incontinence if there is a problem in the sensory system of the bladder, and which is sympathetic,
yes, sir.
isn't it? When sympathetic is a problem, what is the function of what is the nerve intervention, nerve supply of bladder?
Sir, nerve supply of bladder is L2, L3, L4 by the sympathetic nerve.
Excellent.
Parasympathetic S2, S3, S4.
Okay.
And pudendal nerve S4 and S2, S3, S4.
Exactly. Isn't it? If there is a parasympathetic involvement, what is the function of the sympathetic involvement?
So the function of sympathetic
nerves.
The function of sympathetic here is to dilate the detrusor and to store the urine.
Not dilate. It is a motor to the trigone and internal sphincter and efferent for the detrusor. Efferent. It is a sensory system for the efferent.
Yes, sir.
And the efferent is the parasympathetic, which is a motor for the bladder, and it dilates the trigone and also internal sphincter.
Yes.
Yes, isn't it?
Yes,
so when there is a lesion involving those segments, you would get either overflow incontinence or sometimes the frequency of the urine is increased because of the increased sensitivity of the bladder, isn't it? You cannot tell because he is not trained in the toilet training is not done. They will not have bladder issues, isn't it?
Yes.
Okay,
yes.
that's it. Okay, go ahead. One more thing I would like to ask. You have mentioned there are no coffee spots, and you also have told it may point out to neurofibromatosis, isn't it? You mentioned in your presentation. Can you relate neurofibromatosis with the case overall? When we are really looking at the case, we are looking at anatomical structure, lesion, where the lesion is, and we are also looking at the pathology.
Yes.
And we are also looking at what are the complications, isn't it? All those gametes we are looking at. Now you have very well discussed the lesion is down the cervical cord.
Yes.
But now, do you get any clue in the history so that you can exclude? I'm not telling you have.
Yes. Sir, in neurofibromatosis, we can expect ependymomal masses in the spinal cord.
Correct. Yes, you are correct. So neurofibromatosis, sometimes you can present it with a swelling over there, isn't it? And that also can cause compressions. You are telling, isn't it? Okay, that's fine. Very good. Excellent.
Anthropometry, weight is between 3rd and 10th centile, length between the 50th and 90th centile, mid-upper arm circumference is 13 centimeters, head circumference is between 3rd and 50th centile, 45 centimeters. Weight by height is -2 Z-score.
Okay. Aparna, you have anything? Please talk this is because these are some of the things which are new for me.
No, sir.
Because mid-arm circumference, classically we were thinking anything above 13.5 is normal.
Yes.
He has put it 16 and 17 centimeters because I'm not really sure this normal range is woke. Underline, bottom line is woke. Aditya,
Sir.
your comments.
Sir, anything
classically talking, this is helpful from 1 year to the 5 years of age, and anything above 13.5 is normal. Anything below the 11 or 11.5 severe malnutrition. That is classical teaching. Where did you get these figures?
Sir, I took it from.
Okay, move on. No, I'm not really sure. No, not that. Again. What is this Z-score you are talking of?
Sir, here it implies less than 3rd centile, sir. Z-score weight by height is less than 3rd centile.
No, what is the advantage of Z-score or centile or standard deviation? You have mentioned. I'm not asking. You are mentioning that.
Sir, Z-score and statistically it is easier to use it for logistic regressions and all rather than percentiles.
No, that is not exactly. You see, that's okay what you are telling, but Z-score is the one which will indicate the deviation from the mean.
Yes,
Deviation from the mean, isn't it?
Yes.
Okay. So, and if you can tell the formula, I would be very happy. Okay. No, it's all right, because the standard SD, standard deviation, has got a standard units. Standard units. Suppose, for example, you have got a mean of 10 for a 1-year-old child whose weight is 10 kilos. And the first one, the standard deviation may be 12, plus or minus.
Yes.
Second standard deviation may be 14, plus or minus. You are understanding that.
Yes.
But that will only be here. The standard deviation units are 2 kilos, isn't it? From mean to one standard deviation is 2 kilos. From 1 to 2 standard deviation, again 4 kilos, isn't it? These are all standard deviation units. Okay. Suppose somebody has got a 11 kilos. So where do you put him? He is more than mean, but less than plus 1 standard deviation. So then you have what? A Z-score. Z-score is what is observed, that is 11. What is average, mean is 10. And what is the standard deviation unit, that is 2. So how much it will come to? 0.5. Isn't it? So Z-score is 0.5. And that is the importance of that. Okay, go ahead.
Higher mental functions, a child is conscious and oriented to person, child is playful and interested in the surroundings, speech is normal. Cranial nerve examination, first olfactory could not be examined. Second, optic nerve reflexes, direct right reflex normal, fundus examination is normal.
Hold on. Go back. No, you have not. Can you really mention, what you used to call confrontation method or tentality, acuity of vision? You have not mentioned here. You have mentioned pupillary reflection. You have gone for the fundus. Can you make an assessment where it is acuity of vision, even in this age group?
Sir, confrontation method, usually they say it's between, it's done between 2 to 5 years.
Not this age group. That's correct.
Yes, yes,
but
yes.
however, you should be able to assess.
Sir, yes, sir.
Because you have not mentioned about the acuity of vision. I'm not also talking acuity of vision as you had to mention by 6 by 6 as in channel chart.
Yes.
Can you mention? Can you? The common sense. Grandmother will tell whether he has got a vision or not. They won't look at.
Yes, sir.
They won't look at, isn't it?
Yes, sir. Sir, child is recognizing the mother.
Looking at familiar places.
Yes, sir. Familiar places.
Attracted towards the attractive things. So, what does it mean? What does it mean?
Visual acuity is present.
Good. You have not mentioned that.
Yes.
Okay, go ahead.
Third, fourth, and sixth cranial nerves, there is no deviation of eyeball, no ptosis. Fifth cranial nerve, sensory.
No. You see, position you have mentioned, position of the eyes.
Yes.
Movements.
Suppose the position of the eyes is not correct. That means there is a squint. Does it mean there is a problem with third, fourth, and sixth cranial nerves?
Sir, no, sir. Sir, initial squint should be differentiated from follow-up of eyeball on examination, sir. Whereas in a sixth cranial nerve, there will be divergent, convergent.
No, my question is, if you have got a squint, does it always mean there is a paralysis of the extraocular muscles.
Not always, sir.
Correct, correct. What is the
not
situation?
always.
What is the situation? That's it.
Sir, any lesion involving the midbrain, sir, where third, fourth.
Oh, no. Again, midbrain lesion means it is a extraocular muscles are paralyzed.
Yes, sir.
Your answer was in spite of absence of the muscle weakness, the eyeball position may be abnormal. Squint may
Sir,
be.
in myasthenia gravis, it can be.
No. What
No,
is
types of Aditya, types of squint.
Ma'am, exotropic and esotropic and exotropic squints.
That is deviation, whether
Yes.
inside or outside, you're telling.
Yes, ma'am.
Whether there is paralysis or not, depending on that, what is the squint?
Yeah, you know. Then the one is paralytic squint.
Other one?
Non-paralytic. Paralytic and
That's very good.
non-paralytic.
Actually,
So what are other names for that? What are other names?
non-paralytic is correct. Non-paralytic is correct. Okay. No, Aditya, I'm sorry. I'm not making fun of you.
Sir,
You are quite intelligent. You have designed a nomenclature right now. Okay. It is non-paralytic. It is called concomitant.
Concomitant.
Okay, that's right. No,
He knows, sir.
Concomitant squint.
He knows, koncham, he's getting tensed.
Oh, why? It's not examination. It's not nobody.
How to detect concomitant and non-concomitant squint? What is the test? Aditya, are you here?
Yes, ma'am. I'm here, ma'am.
How to detect concomitant, non-concomitant squint? What is the test?
I don't know.
What is the cover, uncover test, card test? Okay, proceed.
You go on. We don't do pediatrics.
Yes,
However,
we do.
however,
Yeah.
you have to know there is something concomitant squint wherein simply by knowing the movements of the eyeball in all directions, you would definitely know that it is not the weakness of the extraocular muscles. It is simply axis of the eyeballs are not properly aligned. Am I clear? Axis of the eyeballs are not properly aligned. Okay. Adults medicine, they would do what is called the cover test, wherein compensatory movement, non-compensatory movement. I am also not really well versed about that. If Aparna, you are well versed, please tell. Otherwise, we'll move on. Okay. Okay. Aditya, you are clear. So, position of the eyes does not really mean third, fourth, sixth cranial nerves are normal.
Yes.
Okay. Go.
Fifth cranial, sensory is normal on both right and left side of the face. Motor examination, no deviation of jaw to either side. Reflexes are normal.
Yeah, no, Doctor. Let's go, sir. Bhaskar garu, are we exceeding the time? Bhaskar,
No issue about the time. There are no time constraints, please.
Okay. Because this is the bedside. Maybe we have to. Diagnosis is quite obvious, right? Diagnosis investigation is quite obvious. I'm not really going to go for that. I do think my co-discussant will agree with me.
Yes, sir.
Why? Because when he tells motor component of fifth nerve, no deviation of jaw on either side. How did he test?
Sir, clenching of, when the child is chewing, when the child is chewing, because the motor innervation of fifth cranial nerve is the masseter muscle, which helps in chewing. We need to observe for deviation of jaw while chewing, sir.
Excellent.
Because it's a 16-month-old child.
Excellent. Masseter, generally when they are chewing, it becomes prominent. It has nothing to do with the pushing of the jaw. Pushing of the jaw is done by pterygoid muscles. Got the point?
Yes, sir.
So you cannot really assess, because in adults we'll ask them to clench the teeth, and when they clench the teeth, we expect the masseter muscle has to become prominent. That is not possible here. But what we look at, which is easy, is when the child is chewing or doing something, they open up mouth. When they open up mouth, the action of pterygoid muscles is to push the mandible towards the opposite side. So if there is a paralysis on one side, then the jaw will deviate toward the same side.
Yes.
Got the point?
Yes.
So it is not that you look for the masseter, but that is okay. That is, you have to look for in a grown-up, but not in the child.
Yes.
Right? Go ahead.
Corneal reflex, conjunctival reflex are present. Jaw jerk is present.
Okay.
Seventh now, no facial asymmetry. No normal auditory function. Child is responding to mother. 9th and 10th cranial nerves, gag reflex is present. Uvula central and position.
Now 7th, 8th nerve has got two components. This is not
Vestibular component and cochlear component.
Yes. You are mentioning about the cochlear component.
Sir,
You are not mentioned about vestibular component. If you are not able to test, that is a different story. But you cannot put them in under one heading. 8th nerve.
yes, sir. Yes.
So only you can tell there is no gross alteration. He can hear grossly, but you cannot tell normal auditory function.
Okay.
Okay.
Yes. 9th and 10th cranial nerves, gag reflex is present. Uvula central and position. 11th now, no wasting or drooping of shoulders, turns head from side to side. 11th now, 12th now, bulk of tongue is normal, no deviation of tongue, no abnormal movements of aspirations.
Supposing uvula is deviated towards the right side, where is the problem?
Sir, it is on the same side of, it is ipsilateral 10th nerve involvement, sir.
No, the function of the soft palate muscles is to pull the uvula towards the same side.
Yes.
Okay. So there will be deviation towards the normal side.
Yes.
Isn't it? Isn't it?
Yes.
Are you getting my point? Are you getting
Yes.
my point?
Yes, sir. Yes, sir.
The muscle, it pulls the uvula.
Yes, sir.
Okay. So that side, if it is paralyzed, something like facial nerve.
Yes.
Okay. It will go towards the normal side.
Yes.
Isn't it? If the deviation is a normal side, then there is a problem on the left side, isn't it?
Yes.
Okay.
Yes.
You got the point. You
Yes,
got the
sir.
point. Right. Now, can you really know 8th nerve and 10th nerve involvement by the history itself?
Yes, sir. Sir,
Because the point why I'm asking this question and going back to the history is, in a paresis, your gag reflex or pharyngeal reflex may apparently normal, but the history will be much more important. That would say, that will give us a clue there is something abnormal there, which is paresis, which is not paralysis.
yes, sir.
And the history is important.
Yes, sir. Sir, 10th now, based on history, we should ask for recurrent choking episodes,
Correct.
regurgitant episodes.
Yes, yes, very good, excellent. There is a drooling, or
Drooling of,
choking smells, or choking spells, occasional choking spells.
yes,
Isn't it? Will indicate there is something wrong with the 9th and 10th, isn't it? But that is much more sensitive, probably, than the gag reflex. Gag reflex will be absent only when there is paralysis.
yes.
Okay, then 11th done.
So 11th now, no wasting or drooping of shoulders. We need to ask for whether the child is having any difficulty in turning the head, head towards the side to side.
Correct, correct. Very good.
And we should look for any drooping of shoulder on any one side or bilateral drooping of shoulders. We need to ask.
Okay, good. Very good. Excellent. No, 9th, 10th, 12th now.
So 12th now, it is motor supply to the tongue, sir. So based upon the deviation of tongue, any fasciculations of the tongue, we need to ask.
You should know, isn't it? Fasciculation, deviation. If it is there, which side it will get deviated, you need to know again.
Yes.
Okay, that's that. Go ahead.
Bulk of the muscle, it's equal on both the sides, bilateral.
No, you have not told about the swelling.
Sir, swelling after the CNS
Did you tell?
examination.
I missed it. I missed it. Or did you tell?
No, sir. I have put it after the CNS examination.
Why? That is part of the 8-2 examination.
Sir.
I'm sorry. I should have asked there. Okay.
Sir, I asked, sir. I asked
you
him. He told he will describe in detail in systemic exam after the CNS. He has just written about the swelling.
You want to tell head and spine, skull and spine. Okay.
Yeah.
Go ahead.
Sir,
Why I'm asking is sometimes if you have multiple swellings like this, particularly if this child has got a similar swelling over the skull, which is painless and which is of about 2 inches or 2 centimeters in size, and you have got a similar swelling here, and that will make us to think one condition which is not unusual you would come across. And I am telling you, it is osteolytic lesion.
Sir, LCH, sir.
I'm sorry. What is LCH?
Lange-Hansel history.
Oh, very good. Excellent. Isn't it? You need to think on those lines. Not that you know the final diagnosis. You are going only on those lines, isn't it? Okay, right? Okay. Now, if this child has to have torticollis,
Yes.
what is the condition which you would think of?
Sir,
He has got a spine problem.
Sir, congenital torticollis involvement of.
I'm not thinking in terms of eye problems. I'm not thinking in terms of sternocleidomastoid muscle issues. Torticollis, I have told eye problem. I'm not telling it is not a sternocleidomastoid. What is the deeper insight? I'm not telling it is a problem with the infratentorial issues. Infratentorial issues also can produce torticollis.
Yes.
Anything connected with the bone, spinal cord, not spinal cord, sorry, vertebral column, which has got which can produce scoliosis, which can produce occasionally kyphosis, and which also can produce later age group. It can produce motor deficits, not necessarily in this age group, but in this case group also you can think of those conditions, and that will be associated with the springill's deformity. I'm telling the springill's deformity also.
Any syndrome starting with K.
Yeah, that's true.
Sorry, my mind.
People fail syndrome.
I
know you are a very good student, and I was told by Aparna, you are an excellent student, but you are doing very well, no problem. But we are teachers. We have to ask something, isn't it? Yes. Obviously, we are like you only. We don't think we are super intelligent. Okay, right? So that is one condition which you may sometimes be thinking, isn't it?
Yes.
And if this child has got a Grotsky features like malaligned teeth, and then he has got a short neck over the trunk, and you may have spinal problems there. I've given a clue. Krotsky appearance, teeth malaligned. And then there is a hepatosplenomegaly, and it is a differential diagnosis for the rickets.
Any storage disorder causing
That's true.
any storage disorder causing dysmorphic features.
Von Gerke's
More than that, one Greek is okay, but that belongs to one group. You have told one.
yes, sir.
What
Okay.
storage will occur in the disorder?
Glycogen storage disorders, ma'am.
Glycogen.
One Greek is a glycogen, but one Greeks will not.
They will have
involve.
4 features, von Gerke's, and glycogen storage will have what type of faces? Sir is telling grotesque dysmorphic features, coarse features with hepatosplenomegaly.
What is the diagnosis for the rickets? Because that means there is widening of the limbs also. No, Van Greek is a.
So many types are there even in this. Where chondroitin sulfate, dermatan sulfate, they
Yes,
are
yes.
deposited.
Yes,
Huh?
ma'am.
What is that group?
It is the GAG is glycosaminoglycan.
Not like.
Is getting mind block. Mucopolysaccharides.
Mucopolysaccharides. Mucopolysaccharides.
That's
MPS.
true. That's true. That's true. It's okay. It's okay. Go ahead. Go ahead. See, we know this is an outright case. You are thoroughly prepared about tuberculosis. I know I am well aware of that. Okay. Okay. I'm not allowing you to go directly like a jet, isn't it? With the due apologies to you and other members of the who are participating in the discussion. But go ahead. Motor system.
Sir, mucopolysaccharides or glycosaminoglycans are the same. Mucopolysaccharides or GAGs are the same.
Chondroitin sulfate is so.
Basically, you will call that group of disorders as mucopolysaccharidosis.
Yes, sir. Yes, sir.
That is what sir was asking. Like glycogen storage
Yes, sir.
diseases.
What I meant was GAG is causing disorders. GAG storage disorder, which meant mucopolysaccharidosis.
Okay, but you may be correct, but those enzymes sometimes we don't remember.
Yes.
It's all right. It's all right. Huh? But you may be correct. If I have not understood you, you have to do apologies. Go ahead. No, you are not told. You are not told that. That's right. Okay.
Yes. Bulk of the muscle is symmetrical on both the sides. Tone, upper limb, it is normal. Lower limb, it is increased on both the sides, more on right side than the left side. Spasticity is present. Power of the upper limbs, it is 4/5. Left, right side 4/5, left 4/5. Lower limb, it is 2/5 and 2/5.
Okay. Hold on. Go ahead. Go. So upper limb is normal. Lower limb it is increased. Okay.
Yes, sir.
More on right side, less on left side. Power again, lower limb 2/5. Okay. Go ahead.
So what is
upper limb also it is not 5/5. It is 4/5.
Sorry, madam.
In power in upper limb, it is 4/5, not 5/5.
Yes, sir. The child is not able to put complete pressure against the resistance offered by us.
You offered the resistance.
Yes, sir.
Do you attend the gym?
No, sir.
Do you attend gym, Aditya?
No, sir.
Your power may be very much overwhelming his power. Isn't it?
Yes.
Now, once you say that is the paresis, you have to explain that.
Yes.
So you may have to put multiple lesions or lesions somewhere above or something like that. You have to be very careful.
I felt that the child had it's not completely offering resistance to my power, sir.
So that you have to explain. I hope you would explain that. You would explain at least in the later in the final diagnosis. Okay, right. Go ahead.
So you define what is tone.
Ma'am, tone is tone can be defined as the resistance. How to define?
Yeah.
This is a passive resistance offered by a resting muscle, ma'am.
Yes. Yes. Resistance offered by, yes, good. Now, here you are telling tone is increased, no?
Yes, ma'am. Tone is increased in the lower
So
limb.
what are conditions where tone will be increased?
Ma'am, UMN lesions, all the upper motor neuron lesions, including the brain, spinal cord, brainstem, all the lesions has to be considered, ma'am. Tone, as a tone is increased, spasticity is present.
Okay. So
No,
if
no.
it is
When he
spasticity,
said- no.
what you are
When
telling
he's
it
telling
is
all, when he's telling
Ma'am,
all,
except spinal shock, sir. Except during the
oh,
phase of
no.
spinal shock.
Cerebellar lesions. Do you get a?
Cerebellar lesions, we have hypotonia, sir. I did not mention
You told all category.
sir, I said cerebrum, brainstem. I did not say cerebellum, sir. Cerebellum is not involved. Cerebellum will have hypotonia.
Cerebellum is not involved. Cerebrum, that's very good, very excellent. So let's not be categorical. Cerebellar lesions, you got a hypotonia. Cerebellar.
So this tone you have told specifically spasticity is present.
Yes, ma'am.
So what is spasticity and with which lesion you will get spasticity?
Ma'am, spasticity is seen in pyramidal lesions, ma'am. Whereas rigidity is usually seen in extrapyramidal lesions.
Usually means what? Usually means what? Unusually. Usually don't use such adjectives.
Sir, spasticity, because rigidity, there are two types where lead pipe rigidity can be seen as a severe variant of clasp knife spasticity, sir. Whereas cogwheel rigidity is present in extrapyramidal lesions.
I don't think. Aparna, you have anything to comment?
What is spasticity? You tell that first. You see cogwheel and lead pipe rigidity in what lesions?
Extrapyramidal lesions, ma'am.
Then you say spasticity, exaggerated form is lead pipe.
Ma'am, yes, ma'am. Spasticity, it is clasp knife. We call it as clasp knife spasticity, ma'am. So it is velocity dependent.
What is the clasp knife? What is the clasp knife effect you describe?
Ma'am, clasp knife effect is velocity dependent. That is, initially it might be normal, but there will be a resistance after some movement, ma'am. Whereas
you are telling reverse. You are telling reverse. Clasp knife.
Initially there will be spasticity, and then there will be a period of, normal tone. So whereas in rigidity, if it is a cogwheel rigidity, there will be equal resistance and non-resistance periods, ma'am. Whereas in a lead pipe rigidity, it is continuous resistance, ma'am. Increased continuous resistance.
See, spasticity, initially there will be some resistance followed by relaxation of the muscle.
Yes, ma'am. Yes, ma'am.
You have anytime you have used a clasp knife, while if you remove what is the clasp knife?
Yes, ma'am. Yes, ma'am. Yes,
and what are the muscles involved in this spasticity? What groups of muscles will be involved?
I did not get them.
Hello?
He has not understood.
See, why are we getting spasticity? Why are we getting rigidity? Rigidity, what muscles are involved? In spasticity, what muscles are involved?
Ma'am, rigidity, it is a flexor muscles, ma'am. Whereas in, spasticity is a flexor muscles. Whereas in rigidity, it is because of imbalance between the gravity and the anti-gravity muscles, both the flexors and the extensors.
So spasticity, you say only flexors involved. In lower limbs, what will be affected? In upper limbs, what will be affected?
Yes, ma'am. In upper limbs, it is the flexors, ma'am. In the lower limbs, if you are testing the knee joint, it is extensors in the lower limbs.
So mainly the anti-gravity muscles will be affected in spasticity, which are the extensors of the lower limb and flexors in the upper limb. Whereas in rigidity, both the antagonist and agonist group of muscles are equally affected. In the most severe form, there will be lead pipe rigidity, where cogwheel is intermittent.
Yes, ma'am.
Isn't it?
Yes, ma'am. Yes, ma'am.
Okay.
Go ahead.
So if there is spasticity, you can tell where is the lesion?
Ma'am, it is
upper motor neuron or lower motor neuron?
Upper motor neuron lesion, ma'am.
So then what are the other points which will help to differentiate upper motor neuron from lower motor neuron?
Ma'am, upper motor neuron, the spasticity will be present, ma'am. Tone is increased. DTRs, deep tendon reflexes will be brisk, exaggerated. Clonus will be present. Group of muscles will be present, ma'am. There won't be fasciculations. Atrophy is less likely when compared with the lower motor neuron lesions.
So, okay, where is
There
the
an
lesion?
element-
In upper motor, you told already which parts will be affected. For lower
Yes, ma'am.
motor, from where does the lower motor neuron start?
Ma'am, lower motor neuron, it starts from the anterior horn cell and then neuromuscular junction in the muscle, ma'am.
Okay. What is this velocity dependence in spasticity?
Ma'am, velocity dependent in spasticity, it is the force with which we,
Velocity
the-
dependence
yes,
or
yes, ma'am.
stretch sensitive, that is.
Yes, yes, ma'am. The thing is, the rigidity they won't differ, ma'am. Whereas spasticity differs with the velocity. What I want to convey.
Okay. So from your features, spasticity is there. You are now at this level. You are telling it is an upper motor neuron lesion. Yes, you can go
Yes, ma'am.
forward. Go forward.
Yes, ma'am. Abdominal reflexes are present. Plantar reflex, extensor response on both the sides. Anal reflex is present. Reflexes, 2+ on bicep jerk and the tricep jerk, upper limb. Supinator is also 2+. Knee jerk is 3+. Ankle jerk and ankle clonus is present.
You told about the power. Now, how do you grade the power for benefit of junior postgraduates? Grading of power.
Ma'am, power is graded from 0 to 5. 0 is no movement at all. 1 is a flickering movement. 2 is against gravity parallel to the surface. 3 is against gravity but not against resistance. 4 is against gravity against not complete against resistance. 5 is complete movement against complete resistance.
So this child has what is the power?
This child has only power is 2, ma'am. The child had only anti-gravity movement, ma'am, parallel to the surface.
So go back for power. Okay. So upper limb, lower limb. So if you can test in an older child, I think you must give for proximal muscle, distal muscles. Like that, you have to give grading. Okay. Yes, so, oh. Okay. How about reflexes? How we have graded the reflexes?
Reflexes is negative +1.
Next slide.
Yes.
Next slide.
Reflexes is negative +1, +2, +3, and +4, ma'am. Minus is absence of reflex. +1 is mild reflex with reinforcement. +2 is normal reflex. +3 is brisk, and +4 is associated with clonus.
So you yourself, you told what is reinforcement we want to know. You told reinforcement.
Reinforcement is like clenching of fist and we call it Genre 6 maneuver, where we ask them to clench the fist or clench the teeth so that
yes, sir. So by reinforcement, you are recruiting more what units? Alpha motor, gamma motor, what units?
More gamma motor units, ma'am, for the tone, for the more gamma motor units, ma'am.
So when you're not able to elicit a reflex, you will do the reinforcement also.
Yes.
Okay. So what are the various methods you told? Clenching of
fists, ma'am. Clenching of fist, clenching of teeth.
Teeth, yes. Okay. Or you can place one limb over the other also. What is this clonus? Where did you see for the clonus?
Ma'am, we have done ankle clonus, ma'am.
Ankle clonus.
Yes, ma'am.
Okay. Did you check for the other sites? What other sites you can check the clonus?
Patellar clonus can be checked, ma'am.
So this child has which clonus?
This child has ankle clonus, ma'am. We couldn't elicit patellar clonus.
Okay.
No, when do you say patellar ankle clonus is positive?
Sir,
Sorry.
sorry, sir, I did not get the question, sir.
When do you say the clonus is positive?
Sir, in
Oscillations. How many oscillations have to be there? When you persistently apply pressure, there has to be oscillations of the ankle, at the ankle joint, and how many oscillations have to be there minimum?
sir, more than 4 oscillations, sir. In neonatal age group, more than 6 to 8 oscillations should be considered.
Okay, 4 to 5. I don't differ that. But what does it really mean? Does it really mean it increased tone or anything infer in what does it clonus infer in terms of pyramidal tract lesions?
Sir, it is one is the increased tone, sir, because of upper motor neuron severe spasticity. It indicates severe spasticity.
That's okay, but that actually I should tell you, sometimes you may not be, see, for the for the plantar, efferent and afferent has to be intact. If there is a problem with the afferent also, you don't get any plantar. In such situations, to know for sure, bottom line, for sure, that there is a pyramidal tract lesions, apart from the other symptoms, clonus important. Clonus presence indicates there is a pyramidal tract involvement. It is as good as plantar.
Yes.
At times, plantar or equivocal and all those things, situations you come across. Okay. Now, I don't know, I would like to ask, what is the root value of supinator?
Sir, supinator C5, C6, sir.
And then abdominal reflexes. You are
Abdominal
not
abdominal reflexes.
Okay,
Yes.
we'll go to the abdominal reflex, then we'll come to all this.
Abdominal
So
reflexes, it is T9, T10, and T11, sir.
So in between, you have
T7.
some problem, isn't it? You are missing segments, isn't it?
Yes, sir.
Isn't it? Isn't it? You have got
Yes,
a still say T7,
T7 to
and then you are jumping to T9 or T. No, actually it is not T9. It is T7, 8, 9, 10, 11, 12.
Yes,
You know,
yes, sir.
it is all right.
Group of-
It's all right. Some people have not taken T7. It's all right. 8 and 9, 10 is umbilicus. Below the umbilicus, 11 and 12, isn't it?
Yes.
So in between some segments you are missing. Is there any indirect way to know those involvement of those segments? Because you told something in your history, he is not able to use truncal muscles. Isn't it? You told that,
Yes, sir. Yes.
isn't it? Can you elicit what is called as a paraspinal reflexes, which we used to do routinely?
Yes, sir.
You apply a sensory stimuli and look for the contraction of the paraspinal.
Paraspinal.
Okay. Go ahead. Go ahead.
So Aditya, with that reflexes, what is your conclusion?
Ma'am, with the reflexes, it is a pyramidal tract lesion, UMN lesion, ma'am, of the lower limbs. I mean, involving only the lower limbs, whereas the upper limbs is normal.
Okay, because exaggerated DTRs, clonus is there.
Yes.
And how about the superficial reflexes?
So, superficial reflexes, the anal reflex is present, ma'am, and the abdominal reflex is also present.
Now, what is pointing towards pyramidal tract lesion?
Ma'am,
Upper motor neuron lesion in superficial reflexes.
in superficial reflex, it is a plantar reflex which is extensor.
Okay. What conditions you can get a physiological Babinski?
Ma'am, physiological Babinski can be seen in deep sleep, less than 1-year-old child, or sedated child. Sedated is not physiological. Deep sleep,
Okay.
less than 1-year-old.
Okay. Deep anesthesia
Deep,
also.
deep sedatives,
Okay.
ma'am. Sedatives and deep
Sir has told for the plantar, we should have the afferents and all should be intact. So you should also know what are the other methods of eliciting the plantar reflex. Can
Yes,
you tell some methods?
Ma'am, one is open hem method, where we scratch along the medial border of the shin from top to bottom, where plantar response will be elicited by the end of the at the end of the test.
You don't scratch. You just apply pressure.
Apply pressure, ma'am. Apply pressure.
Infrapetal. See, my advice to all the postgraduates: if you are having a live examination, maybe you would be asked to demonstrate the other methods in an older child. So everybody should know. Here, anyway, theoretically, he is trying to explain anyway good. At least names. So some of these questions you may be asked just to orient yourself. We are telling. Okay, tell.
Another is
from infrapatellar region, medial aspect of the tibia. That is.
Yes, that is open heme sign, ma'am, or also called as the Shinto reflex. Another sign is the Gordon sign, ma'am, where we squeeze or pinch or apply pressure on the calf muscle. Which is also called as the calf toe sign, where it's also an equivalent to plantar, the Babinski, ma'am. And
Yes.
another sign is pressure around the lateral malleolus, which is called Chaddock sign. Chaddock sign.
Lateral aspect of the foot.
Lateral aspect of the foot, ma'am.
Okay. Chaddock's.
And Bing sign, that is pricking the skin on the plantar surface, ma'am.
I think the dorsum of the foot. No. Okay, you can verify. Okay. Then
I'll see, ma'am.
Okay, it's okay. So these are some of the any more you can tell.
Schaffer sign, ma'am. Pressure on the squeezing deep pressure on the Achilles tendon, ma'am. Achilles tendon.
Schaffer sign is Achilles tendon.
Yes,
okay. Gordon sign is calf muscle squeezing. Okay.
Yes, ma'am.
Then flicking the terminal phalanx of the second or the fourth toe will be Gonda sign.
Gonda sign, ma'am. And
Yes.
extensor response is seen after forceful plantar flexion of ankle, ma'am. That is Munich sign, I guess. Munich.
Okay, these common things you have told very good. What is the equivalent of this Babinski in the upper limb?
I do not remember.
No, what is cortical thumb?
Sir, cortical thumb is persistence of the thumb. Persistent fisting is called cortical thumb, sir. Usually, it is lost by 4 to 5 months. If
persistence of the thumb has to be inside the.
Yes, sir.
You are showing me correct. What you are showing me correct. Isn't what does it indicate?
Sir, it indicates it is usually seen in cerebral palsy cases, sir. Upper motor neuron lesions involving since the progressive neurological disorder since the birth, sir. Static encephalopathy.
Does it have to be progressive?
No, sir. Static encephalopathies can also be.
Can also. Does it indicate any tract lesion? Anything? You told it is a part of the cerebral palsy.
Yes, sir. Corticospinal tract.
Obviously, as simple as that.
Corticospinal.
As simple as that.
Yes,
Madam, Aparna was asking something else. You are asking something else. Aparna?
Yes.
You are asking this?
Yeah, equivalent, sir, in the upper limb. Suppose lower limb, you are not able to elicit plantar. What are the signs? Just you can mention. Already in the chat box, we are getting all answers. Hoffman sign and Tromner signs. Okay, Aditya?
Yes, ma'am.
Okay, you can continue.
Yeah, this is the
video showing the clonus, sir.
No, actually, the way you are eliciting is wrong. Okay, because you have to flex at the hip joint and flex at the knee joint and hold the dorsum aspect of the knee joint and take another hand over the over to the foot solar aspect and then give a jerk. You hear all the joints are extended here.
Yes.
Isn't it? Isn't it? Am I clear? Am I clear?
Yes, sir. Yes.
You have to have a flexion at the hip, flexion at the knee joint, and hold the knee joint and the dorsal aspect.
Yes.
And then with other hand, that give a jerky movement over the polar aspect of the foot. Okay,
Yes.
that is how it is not the method.
Yes. Yes. Yes.
Right. Go ahead.
No involuntary movements, sensory examination, pain and touch normal, cerebellar signs, no nystagmus or titubations, no signs of meningeal irritation noted, ANS, no hypotension.
How did you test the touch in this child?
Sir,
Pain, I understand. Touch,
yes, sir.
tactile sensation.
Sir, the child is responding to touch, sir. I mean, movement of head towards the direction of touch. If I'm holding her hand, she is able to perceive that I have.
See, the point is, when you are eliciting the touch, now you elicit what you call tactile sensation. In the tactile sensation, you elicit as minimal nerve endings as possible.
Yes.
Isn't it? It is not that, it is not a crude touch wherein you apply, you touch a larger area with a little bit of pressure as well.
Yes, sir.
Did you really touch, elicit the touch, which is fine touch?
Fine touch, the child is not responding, sir.
You have to clearly tell, what do you mean by fine touch and what do you mean by crude touch?
Sir, fine touch, we usually do it by a wisp of cotton or which is a fine thing, where crude touch is by a finger touch sensation, which includes a larger area of.
Correct. This is only that. Is only in a fine touch, you are stimulating a smaller area, few nerve endings, whereas in a crude touch, you are eliciting a larger area. Okay. Okay. Does it has any connotation in regards to the tracks? You have fine touch is not.
Yes, sir. We need to see if there is any clear-cut sensory level involvement.
Okay, go ahead.
We need to see if there is any clear-cut sensory involvement to rule out conditions like spinal conditions like transverse myelitis, where clear sensory level is involved, sir. And also here in this case, considering a spinal cord lesion with an upper motor neuron lesion, we'll have to differentiate between an extramedullary and intramedullary lesion, where the difference of sensory examination.
I take your point, but what I was asking is, if you don't have, you have not tested fine touch here.
Yes, sir.
What you have tested is a crude touch.
Crude touch.
Okay.
Yes, sir.
Does it have any connotation, anything to do with the tracts?
Sir, crude, yes, sir. Yes, sir. Yes, sir. Crude touch, sir. Whereas pain and temperature are in a different tract, whereas crude touch and
what is the tract? What is the tract?
Sir, lateral spinothalamic tract, pain and temperature are present, whereas the touch and joint proprioception, crude touch and joint proprioception are present in the posterior tract, where a single lesion usually doesn't involve both. I mean, doesn't involve both the lateral and posterior spinothalamic tracts.
You are not told anterior spinothalamic.
Sir, crude touch is in the posterior tract, sir. Whereas pain and temperature are in the lateral spinothalamic tract. Fine is in the anterior spinothalamic tract. Fine touch.
Okay. That's a classical teaching, but actually, okay, what you are told is correct, but the touch is touch. It is not a fine touch. It is not a crude touch. Fine touch is one you are really testing smaller area for the tactile sensation.
Yes.
And the crude touch is the one wherein you are not only eliciting touch, but also fiber, pressure. You are applying little pressure when you are touching with your hand.
Yes.
That is the reason why you say that it is going through the posterior columns.
Yes.
But actually speaking, this touch is mostly by the posterior column until the spinal cord.
Yes.
Well, I think I have conveyed my message. In a crude touch, you are simultaneously testing the pressure aspect.
Yes, sir. I have one doubt, sir.
Please.
Sir, as a child is a 16-month-old child.
Correct.
Should we appreciate? Consider abnormal. Child not responding to fine touch as abnormal or normal, because, and by what age should we consider fine touch not responding to fine touch as normal.
You have asked a question which I have no ready-made answer, but my common sense tells at 3 years of age, you should be able to.
Okay,
I have not read any textbook. It is my common sense. Okay. If the intelligent child is quite intelligent, quite precociously developed, he may tell at 2 years of age as. Okay.
Yes.
Right. Go ahead.
Examination of spine.
Same slide. Go back. Same slide. You had told cerebellar signs, no titubation. Anyhow, titubation you are told. There are no meningeal irritation signs. Notate. Do you expect meningeal irritation signs in this age group?
Sir, yes, sir.
Yes. Your answer is yes. I take the point.
Yes, sir.
At what age we don't expect, even in spite of meningeal irritation signs would be there, and why?
By what age meningeal irritation signs cannot be expected, sir?
In spite of meningeal irritation.
Signs cannot be expected.
And why?
I don't know the exact answer. 6 months.
Okay. Now, what is it you are doing by eliciting meningeal irritation signs?
Sir, involvement of, any infections, meningitis, sir, and apart from meningitis, meningeal irritation signs can be present in paraplegia lesions like.
No. I'm not asking causes. What exactly you are doing by the manuals? You have got 3 manuals very well known.
Yes,
Actually,
sir.
there are 6 manuals. I'm not going to ask those things. But
Kennick's manual.
what is it you are doing to the meninges when you are eliciting through those methods?
Sir, the basic thing there happens is the stretching of the meninges, sir.
Stretching of the meninges. So that means if the meninges coverings are redundant, they are loose, you will not be able to stretch them by these maneuvers. Is it agreeable?
Yes, sir.
Is it agreeable? It is agreeable, isn't it?
Yes.
Now, till what age the meninges are there till the sacrum or lower end of the L5, L4? If you know that, then you would be, because of till that age, they are all redundant. You will not be able to really elicit, you will not be able to stretch the meninges because they are loose. You should be able to stretch the meninges as to cause the pain through the emerging anterior roots. Is it not so?
Yes, sir.
2 years of age. Okay, 1.5 years also I take the point. Nobody has mentioned this. Okay, so this age I wouldn't expect. Go ahead.
Examination of spine. Inspection. A single swelling of size approximately 5 to 4 centimeters, vertically oval in shape, is seen in the region of the upper thoracic region extending from D4 to D7. Skin over the swelling is normal. No visible scars or sinuses and engorgement seen. On palpation, no local rise of temperature seen. No tenderness. A single bony vertical oval swelling of size 6 into 4 centimeters is present in the region of dorsal thoracic spine extending between D4 to D7. Irregular surface with the distinct edges, and plane of swelling is at the vertebral spine level, and the lesion is not mobile. The skin over the swelling is pinchable, so as to of a gibbous lesion.
No, okay, gibbous lesion. Okay, it's all right. You are sure that it is from the vertebral?
Yes, sir. It's a bony lesion.
The bony
yes,
and skin over the swelling.
Skin is pinchable, and no local rise of temperature. You can rule out abscesses. No tenderness. Osteomyelitic lesions can be ruled out. Chronic osteomyelitis is a consideration, but acute osteomyelitis or brucellar osteomyelitis can be ruled out. Abscess can be ruled out.
You are quite correct. Aparna, you have anything to ask? Please go ahead.
So what is that bony deformity you're telling?
Ma'am,
What is that bony deformity?
Gibbous.
What is knuckle?
Ma'am, knuckle is involvement of only one vertebral body, ma'am, whereas gibbous is involvement of 2 to 3 vertebral bodies or more.
What is angular gibbous and what is rounded gibbous?
Ma'am, rounded gibbous is involvement of more than 3 vertebrae, ma'am. Angular gibbous is 2 vertebral involvement.
So here what she's having, how many vertebrae you could feel by palpation?
3 to 4, ma'am.
3 to
Approximately 3
4.
to 4.
Okay. What are other conditions? Already we had discussed. I think you can just list out the conditions where you can find gibbous.
Ma'am, other infection, one is tuberculosis, ma'am, pot spine. Another cause of gibbous is knuckle, is brucella infections, ma'am. Another is osteomyelitic lesions of the vertebrae and carcinomatous lesions of the vertebrae.
Yes. Other non-infectious causes? Other non-infectious causes? Spinal deformity can be there. We have discussed.
Yes, ma'am. Malignancies is one cause, ma'am.
MPS we thought, no? MPS.
Yeah, yes, ma'am. Yes, ma'am.
Then even in cretinism, sometimes you can get.
Yeah.
Okay.
By any chance, is it a spinal dysraphism?
Sir, spinal dysraphism should be present from neonatal age group, sir, and usually, and it won't be a sudden presentation. I mean, within the 2 months presentation, and bony hard swelling won't be present in a spine.
It is not since 2 months. It is since the last 5 days.
Sir, mother had noticed the swelling since 5 days back.
Exactly.
Sir,
You have hit the nail. Exactly. Mother had noticed. Mother might have not noticed from the birth.
Yes. Okay, sir.
I can extend that logic. I can extend that logic. I'm just telling
you. Yes, sir. Yes, sir. Sir, spinal dysraphism, especially at the spinal, I mean, thoracic dorsal column, thoracic level, if there is a dysraphism, there must be a presentation, very early presentation, sir. And no, I mean, signs like tuft of hair.
What could be the presentation if it is a spinal dysraphism other than swelling, which we are presuming unlikely, but we are presuming mother has missed it. Unlikely. I concur with you.
Yes, sir. Sir, if a spinal dysraphism is present, it usually associates with macrocephaly, increasing head size, the cherry malformations or the Dandy-Walker malformations, associated tuft of hair at the spinal, at the spinal level where dysraphism is present. The child might have presented with the seizures until now, recurrent meningitis. All these symptoms.
Number one, we'll go to one by one. Why do you think they'll present with the recurrent meningitis unless there is a connection to the external environment? That is through the pilodina sinus. Yes. Otherwise, they don't.
Yes, sir. Yes, sir. A sinus.
And otherwise, they don't. So it is not must. Then, why do you think they have to be present always with motor deficits initially? Because if there is a coverings are present, it is unlikely that spinal cord is part of the swelling.
Yes, sir.
Maybe just a meninges with a skin protruding, like a cyst-like presentation, isn't it?
Yes, sir. And one more thing is, sir, if in a spinal dysraphism, they're usually intramedullary cause where sensory involvement will be predominant.
Why do you think it is intramedullary when there is no part of the spinal cord inside? We are telling here the skin is intact.
Okay.
Please, Aditya, let's go slowly. We are talking, the skin is intact.
Okay, sir.
The spinal dysraphism, the contents are not spinal cord. They are meninges.
Yes, sir. Yes.
You got the point.
Yes, sir.
So
yes,
what you are talking intramedullary will come only when the spinal cord is the part of it.
Sir, here spinal dysraphism, a bony swelling won't be present, sir. A hard swelling won't be present.
Okay. That's clear. It is a cyst-like thing, and yes, then that deficiency has to be present. Now, yes, what is called as can this tethered cord syndrome present like this? Tethered cord syndrome, wherein in the lumbodorsal area or lumbosacral area, you may not find anything. What you have taught with the tuft of hair, a patch of hyperpigmentation, or indurator skin or lipoma, etc. Isn't it?
Yes.
May not find anything. And then there may not be any of the swelling also, but as you have pointed out, that may be associated with brainstem involvement like cherry malformation, etc.
Yes.
Isn't it? That's what we are told.
Yes.
And the tethered cord syndrome will not again present. This is the unusual site for the time spinal dysfunction. Spinal dysfunction presents in the
Lumbosacral region.
or at the most lowest thoracic and upper lumbar at the most, isn't it?
Yes.
Okay, that's fine. That's fine. But you have also covered the different diagnoses. I would like to always think in terms of neurofibro, not neurofibroma. What is the neuroblastoma and its secondary lesions? Neuroblastomas can arise from there and can invade the spinal cord. Isn't it through intervertebral foramen?
Yes, sir.
Okay.
Sir, differentiation between this mass and then secondaries to spine. Secondaries to spine, they're usually these are compressive lesions, sir, whereas those are intradural lesions of the spine.
No, hold on. Because you are telling of Kulmas intra. What is the origin of the neuroblastoma?
Sir, neuroblastoma can origin from adrenal glands.
And or from the sympathetic chain.
From the sympathetic chain.
Where is the sympathetic chain? It is extradural, isn't it?
Yes,
and
sir.
As the mass is enlarging, it can penetrate through intervertebral foramen. And when in penetrating, which is the part of the spinal cord which is involved first? Obviously, it is obviously not intramedullary.
Yes, sir.
Obviously, logically, if you go, it has to be superficial to that.
Yes, sir.
Isn't it?
Yes, sir.
That you have to expect root pains and other things, but here also when you are thinking COX, you expect root pains, but that is unusual. It is not there. For anything
Yes.
you were asking, you were
Sir,
telling
primary neuroblastoma lesion can be an extradural lesion, sir.
correct.
Yes, sir. It can be extradural lesion, but secondary, the spinal mass lesion is because if it is because of a secondary, because of hematogenous spread, it can be an intradural lesion as well.
It can be, but it is not necessarily. It can be
Yes, sir.
infiltration only to the meninges.
Yes, sir.
Okay. Right. Go ahead.
Okay.
Other system examination, CVS, respiratory, and GIT are normal. Summary: a 16-month-old female child born out of non-consanguineous marriage, first in birth order, was brought with chief complaints of inability to walk and sit since 2 months, loss of weight and appetite since 2 months, swelling over upper back since 5 days. On examination, pallor is present, increased tone in the lower limbs, spasticity present, exaggerated reflex in the lower limbs, and clonus present, swelling over the upper thoracic spine.
Good. Go ahead.
So now what is the problem she is having anatomically?
Ma'am, anatomically, the problem is at the vertebral levels, ma'am. On examination, you can see it is between on palpation D4 to D7, ma'am. And
that will come for etiology. What anatomically, what is the weakness she is having?
It's an extradural lesion, ma'am, of the spinal
Where
cord.
you are going? Where is the lesion? So what is the problem she is having after your complete examination? What weakness she is having? Where is the weakness?
She's having the weakness of the lower limbs, ma'am.
What is it called? What is it called? Now you can use the scientific terms.
Spasticity, ma'am. Upper motor neuron lesion of the lower limbs at the level of D4, D5, D6.
Is she having a weakness of one half of the body, or is she having weakness of the lower limbs?
Ma'am. Paraplegia. She's having weakness of both the lower limbs and paraplegia.
She's having paraplegia or paraparesis?
Paraplegia, ma'am. There's complete weakness. The child is not able to move anything against distance, only +2 movements.
So they're just only severity. Only paraparesis is partial, whereas paraplegia, complete weakness will be there. Yes. So whatever it is, our approach will be same whether it is paraplegia or paraparesis. Okay. Yes. From your examination finding, is this what is the type of paraplegia she is having? Next.
Ma'am, paraplegia, it is actually divided into two types, ma'am. One is based on completion, whether it is a complete paraplegia or incomplete paraplegia. Here it is an incomplete paraplegia, ma'am. There is no involvement of sensory and other sensory involvement. Only motor involvement is present, so you can assume it to be incomplete paraplegia. And other classification is whether involvement of extensor and flexors. Extension, paraplegia in extension and paraplegia in flexion, ma'am. If only pyramidal tracts are involved, it is a paraplegia in extension, whereas the paraplegia in flexion is a severe form of paraplegia in extension, where both pyramidal and extrapyramidal symptoms will be extrapyramidal tracts are involved. In paraplegia in extension, it is usually the extensor reflexes which we see, whereas in paraplegia flexion, the DTRs are lost, ma'am. Because of severe spasticity and severe the DTRs are lost.
So depending on the tone and depending upon the level of lesion, depending on the tone, how do you classify this paraplegia?
Ma'am, it is a UMN type of extensor incomplete paraplegia in extension at the level of D4 to D7.
I'm not asking in this child. We'll go about stepwise. Okay. See how to approach a case. So now this is what type is it? Spastic or flaccid type?
Spastic type, ma'am.
This that is what. So spastic type, in spastic paraplegia, where can the lesion be?
It is before the anterior horn cell, ma'am. In the pyramidal tracts, lateral corticospinal tract.
So it can be in the cortex, or it can be in the. Can it be in the spinal cord also?
Yes, ma'am. It can be in the spinal cord as well.
So flaccid type will start from where?
Ma'am, flaccid type will start from the spinal cord interior. It is a gray matter. It will start from the anterior horn cell, ma'am.
Horn cell.
From
So
the anterior horn cell and then
horn cell and beyond, we have already discussed while classifying what is upper motor neuron and lower motor neuron lesion. Yes. So flaccidity will come from anterior horn cells and below. Whereas spastic type, the lesion can be in the cortex or in the spinal cord. So in the central cause of spasticity, what are the features which will suggest that it is a central cause? And where would be the lesion?
Yes, ma'am. Ma'am, for it to be called a central cause, spasticity is there, ma'am. Spasticity, we can say it as a central cause, whereas if it is a peripheral cause from the AHC anterior horn cell, it is usually the child usually presents with flaccidity.
Aditya, now in spastic only, how to differentiate a central cause and a spinal cord cause? What are the features which will suggest it is a central cause?
Ma'am, absence of altered sensoriums, loss of seizures, involuntary movements, cerebral causes can be ruled out, ma'am. Spinal cord causes can be considered.
Because they are absent. So where will be the lesion if it is in the cortex? What is that region called?
In the spinal cord, ma'am?
No.
In the central causes, in the cortex, where will be the lesion? To cause only lower limb paraparesis.
It is the involvement of the corticospinal tract, ma'am. Lesion in the corticospinal tract.
Where exactly in the center?
Where exactly? What is homunculus? What is homunculus?
Homunculus is arrangement of the
So it is arrangement of
motor fiber innervation to the particular parts of the body where
so different regions of our body represented in the cortex. They are represented as the homunculus. So now mainly in your case, lower limbs are affected. So where are the lower limb fibers?
Ma'am, lower limb fibers are towards the outside, ma'am, whereas the cervical fibers are towards the inside.
What is
What
that?
Ma'am,
What is parasagittal lesion? So medially it is located. Lower
Yes,
limb
ma'am.
fibers are located medially. And along with this lower limb fiber, some other organ also center is there. So if that involvement
it is
there,
bowel and bladder involvement, ma'am. Bowel and bladder involvement. Is
so
also associated.
so you have told about the other features where when center is involved, what features can be there. And if usually the lesion is in the parasagittal region, then even bladder involvement may be there. So because all these features are not there, we are not thinking of a central cause. Next,
Yes.
come to the spinal cause. Spinal, where in the spinal cord can be the lesion?
Ma'am, as lower limbs are involved and sacral segments are usually towards the outer side and cervical lesions are towards the inner side. The lesion is usually, the lesion is from the outer direction, ma'am, not from the inner direction. So here we need to consider it as an extradural, extramedullary lesion rather than an intramedullary lesion.
Hello?
Yes, ma'am. Audible,
Ah.
ma'am.
I could not
Hello?
hear.
Ma'am, as the lesion, as here the lower limbs are involved, the sacral segment in the spinal cord is towards the outer surface, outer side, and cervical segment is towards the inner side. Lower limb involvement is present, ma'am. So here we need to consider compressive masses, ma'am, like the masses from the outside, like the extradural masses rather than the intradural masses which arise from the spinal cord.
So, okay. Sir, Eman adutara, sir?
The point is, so, he has already explained that, but can you explain how the abdominals are spaced? Because you are putting the lesion at 5, 6, 7, isn't it? If I'm correct,
Yes,
isn't
sir.
it? And the 5, 6, 7, you are telling basically, you are talking of vertebrae.
Yes, sir.
And the corresponding segments, you can add one place, isn't it? One
Yes,
place,
sir.
isn't it? So if I add one place, the corresponding lesion would be 6, 7, 8, isn't it?
Yes, sir.
Okay. Now, how is the abdominals are spared when you have told the 8, 9, 10, 11, 12?
Yes, sir. Abdominal reflexes are present, sir. Anal reflex is also present.
How do you explain that?
Sir, in a UMN lesion, be it a deep tendon reflex or a superficial reflex, the reflexes will be exaggerated, sir. If the abdominal reflexes are absent and even the anal reflex is absent, then we can
Basically, to be very frank, Aditya, I have not tested many times anal reflex, for many reasons. But I'm happy that you have tested that, isn't it?
Yes,
I'm quite happy. But let's talk about abdominal reflexes.
yes, sir. So if it's an LMN lesion, the reflex might be completely absent, sir. Whereas here,
for a reflex to be present, there has to be afferent and efferent, isn't it?
Yes,
and now you are telling the lesion is 8, 9, 10, or sorry, 6, 7, 8, and upper abdominals have to be involved.
yes, sir.
Well, why you are not involved here?
Sir, abdominal reflex I have involved, sir. I have put it as plus. Abdominal reflex is present.
Present, that's what, they have to be absent.
Sir, because it's a human lesion, the abdominal reflex has to be present.
Actually, okay. So there is nothing like exaggerated abdominal reflexes.
Sir, actually I have demonstrated, I have done, sir, but I couldn't get exaggerated reflex like the beaver sign movement of umbilicus above. I couldn't appreciate that, sir. Hello.
Hello, sir.
Sir has lost connection.
Connection mainda. Okay, we'll continue. So this is either in central causes or spinal causes. In spinal causes, you say it is from extradural.
Yes, ma'am.
So what are all the extradural causes?
Ma'am, extradural causes are PATS spine, ma'am. Ma'am, am I audible, ma'am?
Yeah. Yes.
Ma'am, bony.
Hello?
Ma'am, I'm not able to hear anything, ma'am.
I'm not talking.
Yes.
Somebody else is speaking.
Yes, ma'am. That's what I'm not
Okay,
able
you
to
continue.
hear. I'm not able to hear their voices.
Okay.
Ma'am, it can be one PATS spine, ma'am, carry spine, any extra compressions, ma'am, abscesses, extradural abscesses, paraspinal abscesses, hematomyelias. These are all extra medullary causes, ma'am.
Extramedullary cause. So
bony
how do you
metastasis,
classify the spinal lesions? You told extramedullary. What is the other one?
Ma'am, extramedullary and intramedullary, ma'am. Again, intramedullary can be divided into whether it is dural or within the dura, intradural.
Extramedullary can be divided into intradural and extradural.
Intramedullary, ma'am. Intramedullary can be divided into intradural or extradural.
Is it so? How to differentiate intramedullary and extramedullary?
Ma'am, intramedullary, because the lesion is arising from the inside, the sensory involvement is more common, ma'am, and and it does not involve the roots. So root pain is present in extramedullary, ma'am, and as cervical component is present towards the internal part, and sacral part is towards the later part. There will be sacral sparing. There will be sacral sparing and also the sparing of the posterior column, ma'am, where crude touch and joint proprioception is present. So there will be dissociate type of sensory loss in intramedullary lesion, whereas sensory loss is late and descending type, ma'am, in extramedullary lesion. Because cervical lesion is involved, early in the intramedullary lesion, it is usually early and descending, ma'am. Cervical, thoracic, lumbar, and the sacral. Whereas in an extradural, a sacral is involved first. There is an ascending progression, ma'am. Bladder involvement will be late in extradural as it is present towards the center. Bladder involvement will be
extradural. Bladder involvement will be present in. You are getting confused.
Ma'am, bladder involvement is late presentation in extradural, ma'am, whereas it is an early presentation in
extramedullary. On the whole, extramedullary bladder involvement is late. It is in intramedullary, around the central canal, the bladder fibers will be there. So in intramedullary, early involvement of the bladder will be there, and dissociate type of anesthesia will be there. Why dissociate anesthesia?
Ma'am, dissociate anesthesia because the lateral spinothalamic tracts are involved early, whereas the posterior tracts are not involved, ma'am, as they are present posteriorly. So as only the pain and temperature are involved and proprioception and crude touch are not involved, it is called as dissociate anesthesia.
Okay, you want to change again spinal, it can be intramedullary. The extramedullary is intradural and extradural. You got confused. It's not intramedullary.
Yes, ma'am. Okay. And one more important thing is in extramedullary, there might be unequal asymmetrical involvement, ma'am. Whereas in an intramedullary lesion, it's usually equal, symmetrical involvement.
Symmetrical involvement. Okay. Now, so here, what next thing is, now you have told it is a paraplegia, which is spastic type, and the lesion is in the spinal cord, and even in spinal cord, it is extramedullary and extradural, isn't it?
Yes.
So now next comes, what is the etiology?
Yes, ma'am.
What is the lesion we have done? Where is the lesion? Where is the lesion we have done? Now we have to see what is the lesion.
Yes, ma'am. Here, according to our history, we do not have any history of TB contact, ma'am. Usually, the most common cause of gibbous spine lesion is PATS spine. According to Walgenstein table, development of spine tuberculosis within 2 months is unlikely, ma'am. It usually takes more than 12 months to 24 months. And another possibility is chronic osteomyelitis of vertebrae and Brucella osteomyelitis, ma'am. But Brucella osteomyelitis is usually present with a knuckle, only a single vertebral involvement, and that too in a sacral level or a lumbar level, not in a thoracic level, ma'am.
Okay. What are points supporting?
Points supporting are
Infectious or inflammatory. So for postgraduates, you classify, you remember what you may already be, you may be knowing for what is the lesion. All of you know that the mnemonic is vitamin. So depending in that vitamin also, the vascular causes, the inflammatory and transverse myelitis, autoimmune, all these can be acute. So here in this child, he is presenting as a subacute or a chronic condition. So we can rule out those acute conditions. Okay. So what are the points favoring these infectious causes?
Ma'am, favoring infectious causes, there's no history of fever or other symptoms, ma'am. Here, the one point that is supportive of tuberculosis PATS spine is the loss of weight as given by mother, ma'am. History as given by mother.
Okay. Sir, anything you want to ask, sir? Narasimha Rao, sir. Sir, unnara?
Yeah, Dr. Narasimha Rao sir's mobile cell is discharged. He went down to get the battery charger.
Okay.
In the meantime, madam, if from your end, if it is over, we will ask Dr. V. Ram Narasimha Reddy to make the.
So how do you want to investigate this case?
Yeah, please go ahead, madam. If it's not completed, please go ahead. Dr. Narasimha Rao will be joining.
Okay, sir. Okay, sir. Aditya, investigations. What investigations you want to do?
Ma'am, investigations, we need to get a complete hemogram, ma'am. And then as pallor is present, we need to get a complete hemogram and iron folate studies and vitamin B12 levels. And as we are suspecting TB, we need to get a TB workup done, get a chest X-ray, ESR levels, MON2, CBNAT, ma'am. And as there's a clear-cut lesion in the spinal, in the thoracic region, spine, an MRI, we should get an MRI done.
Okay. You have taken X-ray spine?
Yes, ma'am. X-ray spine, chest X-ray, X-ray spine.
You can project those investigations.
These are the investigations, ma'am. Complete hemogram, hemoglobin is 7.7, WBC is 13,800, RBC is 3.1.
So what is abnormal? You can tell that.
Yes, ma'am. Nutritional anemia is present, ma'am. Microcytic hypochromic anisocytosis with decreased indices MCV, MCH, and MCHC. Retic is normal. Electrolytes are normal. Urea, creatinine, and calcium are normal. Brucella antibodies were done to rule out brucella, which is negative. Liver function tests are normal. ESR is elevated, ma'am. 46 mm in the first hour and 96 in the second hour. Gastric aspirate for CBNAT, which was done, was negative. HIV of mother was done, which is not negative. MON2 test was done, which showed 17 mm. This is the chest X-ray, X-ray spine in the lateral view, X-ray spine. This shows two paraspinal masses, ma'am, measuring almost 3 to 4 mm on both the sides, paraspinal masses which are compressing the spinal cord along with the gibbous deformity. This is the MRI picture, ma'am. Complete destruction, vertebral destruction of D5, D6, D7, lesions being osteolytic. So CT, ma'am, CT. And here you can see the calcifications, ma'am, which are supportive of tuberculosis. Calcifications in the paraspinal abscess. MRI spine was done, which showed severe kyphotic deformity at the D5 level. T2 still hyperintensity is noted in D5, D6, and D7 vertebrae with the destruction of D6 vertebrae. Collection measuring 24 into 26 into 29 and almost the same size on both the right and left side. Collection is seen extending into the anterior epidural space, causing narrowing of the spinal canal with maximum diameter of only 7.3 mm at the D6 level. Narrowing of D6, D7 intervertebral disc space noted. Multiple conglomerate lymph nodes noted in right paratracheal region. So almost measuring 2 centimeters into 2 centimeters into 2 centimeters, which is significant. And fibrotic changes which are not palpable on our clinical examination, we can't palpate them. Fibratic changes noted in bilateral apical lobes, spleen and liver size normal. Likely tubercular spondylitis with pre and paravertebral abscess and multiple conglomerate right paratracheal lymph nodes. MRI brain is normal. This is the MRI scan report. Epidural, this is the epidural abscess causing compressive effect on the spinal cord. Yellow arrow is an epidural abscess, whereas the green arrow shows the paravertebral collection. Outside the vertebral column. These are the paravertebral.
Tell your final diagnosis.
Yes, ma'am. These are the multiple conglomerate lymph nodes in the right paratracheal region. Diagnosis is tubercular spondylodystitis, D5, D6, D7 with myelopathy, causing incomplete paraplegia, with primary focus being paratracheal lymph node TB with moderate acute malnutrition.
Okay. Good, well presented.
Thank you.
Well presented.
Thank you, ma'am.
Sir, ochara, sir?
In the meantime, we'll ask Dr. Ramnarsa Reddy sir to.
Okay, sir. Okay, sir.
Sir, Dr. Ramnarsa sir, go ahead, please.
Sir, వచ్చినట్టున్నారు.
ఇప్పుడు వచ్చారు డాక్టర్ నరసింహారావు.
Yeah, are you able to hear me, Raj?
Yes.
Are you able to hear me?
Yeah. We are able to hear you.
I'm sorry. There suddenly there was some problem with my battery. I had to, and I believe he has presented very well. And
Sir, we have
more than our expectation. Hello.
We discussed what is the lesion, and
your voice is quite low, Aparna.
Sir, we discussed what is the lesion, where and why.
That's very good. That's very good,
sir. And he has projected the investigations and the final diagnosis, sir.
Okay, good, very good. And what is the treatment options he has taken?
We have not discussed the treatment, sir, still.
Because this child already has a paraplegia, and I think it is too late, actually, to be very frank.
Yes, sir.
Why this was the surgery was taken up for this child or not?
Sir, we have referred it to the neurosurgery department.
I'm sorry, I'm not able to hear you.
Sir,
little loud.
sir.
There is some problem with my computer. I have not made a. See, Aditya.
Sir, yes, sir. We have referred it to the neurosurgery department, sir. We have taken opinion from two departments, one from the NIMS and one from the Osmania. They said both the neurosurgery departments said the surgery is a must. Decompression surgery has to be done as severe kyphotic deformity is present with paraplegia. Surgery has to be planned as soon as possible, sir.
But okay, anyhow, that's okay. And meanwhile, anti-tubercular drugs you have started?
Yes, sir. Anti-tubercular drugs has been started, sir.
What is the regime? What is our regime?
Sir, here it is intensive phase, continuous phase, and the prophylactic phase should be given for around about 18 months.
What is the intensive phase?
Sir, intensive phase, 4 drugs has to be given, sir. HRZE and in continuous phase, 1 drug can be removed, HRZ can be given, and then prophylactic phase only rifampicin and isoniazid.
What is this prophylactic phase? How long you want to give prophylactic phase?
Sir, prophylactic phase can be given for 4 to 6 months. Can be given for 4 to 6 months.
No, because this is something. What is this prophylaxis for? What is this prophylaxis for?
Sir, because this is a spinal TB, as a bone TB, decreased drug penetrance to at the bone level, sir. So, so we need to give prolonged phase for the lesion to not recur.
Anyhow, I am not able to hear. But point is the nomenclature which you are using, prophylaxis, I don't think is mentioned anywhere.
Sir,
as a prophylaxis. Over and above 4 months of your maintenance by 3 drugs, is it mentioned as a prophylaxis?
I have seen in one presentation, sir. So I have
no, it is not question of presentation.
Prophylaxis for that. Do they use the term prophylaxis for that?
I have seen it in one presentation, sir. So I have quoted it.
Okay, but anyhow, but you please correct that.
This
There is
continuation
nothing like
phase,
prophylaxis here.
continuation phase, that's all.
Okay, sir.
Longer
Isn't
delay.
it?
Extended.
Isn't it? Okay, that's fine. You have done it well.
Any steroid was given?
Okay.
Yes, ma'am. Steroid was given.
What is the role of steroids?
Sir, to decrease the edema, compressive symptoms can be decreased.
I'm not really sure, but I don't know. Then Aparna and Narasimha Reddy agrees with this or not. I am not sure steroids are indicated in the spinal cord or the spot spine.
Sir, here in this case, apart from deformity, there are epidural abscesses and paraspinal abscesses present, sir.
Even if there is a cold abscess, because you expect cold abscess to be there, after all, from the necrosis of the vertebral body, it can project into the spinal canal. It can produce. I'm not denying that, but does it volunteer us to give steroids? That is the question. And it is not a standard recommendation.
Yeah, yes, sir.
I don't know. VN Reddy, Narasimha Reddy, you agree?
Dr. RSV, can you unmute Dr. Ram Narasimha Reddy? Dr. Sri Krishna? The problem is the host has not unmuted him. That is why he is unable to
Speak.
Dr. RSV.
He is not. At least Aparna can participate.
Sir, only to reduce the edema, sir, we have to give initially. Actually, our classical teaching was we have to refer to neurosurgery once there is neurological involvement. But now the neurosurgeons are of two opinions. They want to try for 2 weeks ATT along with steroids and then go for surgery.
See, the point is, now let me tell you, when as a clinician, we need to know what the paralysis is because of the edema or because of the damage to the structural problem. If it is to be edema, as you see in TOTS paralysis, edema will recover as soon as you take care of underlying problem. But if it has gone to the extent of damaging the fibers, there is no need, there is no role of the steroids. And even in the earlier stage also, steroids, if you look at the recent recommendations of national program, steroids, they have just put it only for TBM and also to miliary tuberculosis. We used to give for the pleural ascites, we used to give for pleural effusions. And even meningitis, we used to give for 2 to 3 months. Now they have made it to 4 weeks to 6 weeks.
4 to 6 weeks.
Hello.
Okay, fine.
Okay.
Okay.
We are ready.
Okay. As a very nice case presentation and history taking everything. Coming to steroids, the general rule, anyway, under the cover of appropriate treatment, a short course of steroids can be given. Under the cover of appropriate management. As you said, usually steroids are given for the management of to decrease edema around the structures. When the structural abnormality is there, they are contraindicated, as you said, Narasimha Rao sir, rightly. But the rule is, as Aparna madam says, a short course of steroids can be given under the cover of appropriate management. You know, the very nice discussion we had all the time, Narasimha Rao garu and our Aparna madam. You know, I wanted to say few things about the, as he presented Aditya very nicely. Only thing is the classical difference between history and physical examination. History, number one point, it will tell you about the disease process. Whereas physical examination will tell you about the patient condition. That's very, very important, number one point. And number 2 point, history will run over a period of time, fixed period of time. That is the story of the disease process and it runs over a period of time. Whereas physical examination depends on the condition of the patient at point of time. Physical examination, point of time, history, period of time. That means the history is always constant. Whatever Rama told my grandfather, Rama, Sita married, same thing. Even by my grandson, the same thing. So, but patient condition is always variable, depends upon the point of time. That is the reason why we teachers always tell the students, examine a sick child as many times as possible, because condition will be changing every time. This is coming to history. And one Narasimha Rao sir, I asked one sentence regarding the history of 5 days of swelling. See, whenever they are giving chief complaints, you should put them in a chronological order. Once you are taking the history of present illness, each complaint is described, onset, duration, and ending. In that, you can ask leading questions. In complaints, you cannot ask leading questions. But history of present examination, you can ask leading questions. Then we will come to know, as Dr. Narasimha Rao told, that it is not there for 5 days, that swelling might be there even before also. Mother also told you, you are Aditya. That means when you are taking the history of present illness, again you can reorder the chronology of the chief complaints, what they told in the beginning. This is called what our teacher told, khud ka nakhal marna. You should copy yourself. Again, they should put them in order. That's very important regarding the history. And Aparna madam was specifically mentioning, after a chief complaints, history of present illness, always you should come to provisional diagnosis. Why should come to provisional diagnosis? To know the probable etiological conditions for your diagnosis. Then only you can ask your history, no history, positive history, negative history, aggravating factors, relieving factors. Once you know the etiological factors for your suspected provisional diagnosis. In that, she was clearly mentioning the provisional diagnosis, what is called etiological diagnosis, that we have to do provisional diagnosis very clearly. And coming to one word regarding CNS, they take on, most of the postgrads have problem. Upper motor neurons, they control you and Adampodu raste wo aitade, opposition of the body, opposite part of the body. Upper motor neurons always control the opposite side of the body. They start from pyramidal tract, from bed cells, subcortical area, extrapyramidal system. This pyramidal system, extrapyramidal system are two only upper motor neurons. They supply control opposite side, upper motor neuron, opposite side of the body. Lower motor neuron, as Dr. Narasimha also mentioned, cerebellum, brainstem, spinal cord. Lower motor neuron, they supply on the same side of the body. This is one clear point you should know. Coming to one more point, these upper motor neurons, they usually start from bed cell, cerebral cortex. The main function of upper motor neuron, whether pyramidal tract or extrapyramidal tract, is two eyes, eye, frontal lobe, eye. Initiation and inhibition of volition, voluntary movements. Initiation and inhibition of voluntary movements come from that. And coming to here only, I want to make it very clear, Babinski sign positive means the upper motor neurons cortex is not fully developed. There is no inhibition. When there is no inhibition of higher cortex, then you will get Babinski sign positive. That is present in children, newborn up to age of 2 years or 1.5 years, because cortex is not fully developed. Usually by third birthday, this full cortical development takes place. And is also present during unconscious because cortex is knocked out. And is typically present if you observe generalized convulsions. Typically, if you observe the patient during generalized convulsion, Babinski sign is positive. And this is observed in psychiatry when they are doing electroconvulsive therapy, because upper motor is knocked out. So you will get Babinski sign positive. And coming to one point, as Narasimha was repeatedly asking, control of bladder, there is a lot of problem. Sympathetic, parasympathetic ante passing urine, urine pass cheyalante parasympathetic, poyadda ante sympathetic ante. Poyyala kabatti adi efferent. What Narasimha was telling, parasympathetic efferent ante passing urine efferent. పోయేది కంట్రోల్ చేసుకోవాలంటే ఫర్ సింపథెటిక్ కంట్రోల్. So that is the passing parasympathetic for passing urine, and sympathetic is for, and anyway one important, sometimes you'll ask in postgraduate and everything, for ejaculation is the sympathetic sexual activity. Ejaculation is sympathetic, but for passing urine is parasympathetic. This is one important. And coming to the cranial nerve examination, madam was asking one question. Whenever you examine cranial nerves, you can be examined the newborn, adult, old age, conscious, unconscious. Any child you can assess cranial nerve examination. In assessment of cranial nerve examination, always it is not examination at all. First it is history. I think both these sirs were asking you, both Narasimha Rao as well as Aparna. Any cranial nerve examination, first history, then examination. I'll start here, very important cranial nerves in the examination. We'll start with 12th nerve examination. History, నీకు బాగా నమలస్తుందా నమలస్తలేదా, with the tongue is moving or not. Whenever you want put out the tongue, I got both tongues are coming out. When the right is paralyzed, I am not able to put the right tongue out. So left tongue is coming out. So it pushes the tongue to the right side. In 12th nerve paralysis, right side paralysis, when right tongue is paralyzed, left tongue is pushing out, so tongue is deviated to deceased side. 12th nerve paralysis, tongue is deviated to the deceased side. Whereas jaw, tongue is attached to the, this is where you can remember. Tongue is attached to the lower jaw. In the jaw also, fifth cranial nerve paralysis, when you want to open the mouth, we got two mandible. Right mandible is paralyzed, so left mandible is pushing towards the right side. That is a powerful action of medial pterygoid muscle. That means 12th nerve, whereas 5th nerve నాలుగే లోవర్ జాకే అతుకొని ఉన్నది. ఈ రెండు పెరాలసిస్ లోపట 5th nerve, 12th nerve paralysis deviated to the disease side. There's a lot of confusion in examination. Whereas 7th nerve, as Narasimha Rao very clearly said, when you want to say, oh, both soft palates are going up, whether right palate as well as left palate. When right paralysis, right palate is not moving, left palate is moving, so uvula is lifted towards left. That means in 10th nerve paralysis, uvula is deviated to normal side. In the same way, in the 7th nerve paralysis, whenever say E, when a right side paralysis is there, right angle is not moving, left angle is moving, so it pushes back. So that means 7th nerve and 10th nerve paralysis equal to 17, deviation towards normal side, whereas in 12th nerve and 5th nerve, deviation towards the disease side. This is one more thing I want to, pyramidal and extra pyramidal. See, the lot of confusion, as madam was very clearly explaining, Aparna madam. Pyramidal, pyramidal, spasticity, P, clasp knife, P, all P's are there. You can way of remembering how we remembered. Pyramidal, clasp knife, whereas spasticity, and it is good anti-gravity group of muscles. What are the anti-gravity group of muscles? You should sit down and try to stand up. Whenever you want to try to stand up, then you will get action will be there. These are anti-gravity group of muscles. Whereas extrapyramidal will control both flexors as well as extensor, gravity and anti-gravity group of muscles. Both muscles are affected, so there is a tone is very much increased. That is called that is called rigidity, more rigid. They are both are involved. That's why you'll get a lead pipe rigidity, like eyes were bending the lead. It is continuous. Whereas intermittent cogwheel rigidity, typically we will find in Parkinsonism. So, and pyramidal tract only standing up, anti-gravity group of muscles. Extrapyramidal tract, both group of muscles are involved, so you will get rigidity. This I want to tell few things which are anyhow very nice. I think anyhow we are not going to, already madam has got very clearly into the pyramid spasticity, extra dural work. I'm not going. Anyhow, thank you very much for giving the opportunity. Nice to see Dr. Narasimha Rao garu and as well as Aparna and Bhaskar. You know, this I want anything what What do you say, Narasimha Rao?
No, you have summarized very well all the important issues which will arise, particularly when we are present in the case examination.
Yes.
I think over to Bhaskar.
Thank you very much, Dr. Narasimha Reddy garu, for your excellent remarks with wisdom. They may look simple, but they're very useful in clinical practice. And my profuse thanks to Dr. Narasimha Rao and Dr. Aparna Madam for continuing this PG clinics for 2 hours, 25 minutes.
Okay.
An audience
Sir,
of,
I thank all of you. No, sir, I thank all of you for
Aparna, thank you very much, Aparna.
Yeah,
1.5 years, 1.5 hours extra.
Aparna, thank you. Aparna, thank
you're
you.
welcome, madam.
Thank you for your excellent comments, sir.
Okay.
With an audience of 100 members in this Zoom and more than 60 members in YouTube. And to our present surprise, even to this time, there are 77 participants in Zoom and 51 in YouTube. It shows their enthusiasm and interest in academics. And amazingly, you made IAPTCB proud about after having this IAPTCB clinical meeting. And you had set high standards for the ongoing 11 IAPTCB clinical meetings. Now it's a tough task for me to choose whom should I choose, from where I should get the professors to be on par with you. So once again, thank you all.
There are plenty, and probably some people are silent.
I really appreciate
Aparna is quite a silent worker. Aparna is always quite a knowledgeable, and she has got a fine knowledge.
I really appreciate our participants, particularly our PG students, were responding so promptly with all correct answers. Correct answers. Had Aditya been little more genius, if he had seen in chat box, his answers would have been more than correct.
वो खुद का नकल मारना है, वही है, खुद का नकल मारना.
Thank you, Aditya. Now, Aditya before this IAP clinical meeting was different, and Aditya after this clinical meeting is different. Okay. And really,
Aditya, one thing, one word I want to tell you. Aditya, whenever even Sankoch Bhaskar also, whenever you are giving speech or whenever you are talking, you should think that all those who are listening, they do not know anything at all. If you think that they know everything, then you cannot talk. So when you are listening to a teacher, you should think that I don't know anything. When you are listening, you should think that you don't know anything. When you are speaking, you should think that you know everything. This is the way, then you will not have any fear. What do you say, Narasimha Rao garu?
Yeah. Oh, absolutely. These are all pearls of wisdom. I always tell, pearls of, I was very happy, when I saw your face, and these are all
thank you all, and I request Dr. Vamshi.
1 minute, sir. I want to tell. I want to thank Dr. Narasimha Rao for his encouragement. From my PG days, he was only my source of encouragement, sir. I thank you, Dr. Bhaskar, sir, for giving me this opportunity, and the entire IAPTCB team, and Dr. Ram Narasimha Reddy for your excellent comments and experience.
For everywhere, every time you will give comment.
Congratulate the postgraduate. Presented well, sir.
Yeah, postgraduate presented well.
Just one more minute. Our treasurer, Dr. Vamshi, will.
All audience for bearing with us. We have exceeded the time by 1.5 hours, I think. 1.5 to 2 hours.
They bear not for us, madam. They bear for themselves. They want to bear, so they bear not for us.
Unmute Dr. Vamshi. Dr. Sri Krishna, please unmute Dr. Vamshi.
Good afternoon, all the senior professors, PGs, and it's should say with all experienced people around, and my dear professors, and the students are also excellent, and this is a wonderful session and a wonderful opportunity to learn and relearn, and this is a time to apply and remember all these important wisdom points in presentation. How Narasimha Rao sir, Aparna madam, and VRN Reddy sir, thank you so much for making this IAPTCB program successful. And I should especially thank all the PGs, and my IAPTCB president Sankoch Bhaskar sir is same, like he is breaking his own records, that the session has gone from good morning to good afternoon. so this is wonderful and it is successful. And Secretary, thank you for making this program lively, reach all the needful people, and let's continue conducting these programs like this. So wonderful case discussions. Thank you for all the participants.
Okay,
Aditya
congratulations, Bhaskar. Congratulations, Bhaskar. Bye.
Thank you. Thank you, Bhaskar. Thank you, Aparna. Thank you.
Thank you,
Thank
sir.
you, Vamshi. Thank you, Sri
Sir.
Krishna. And a wonderful, wonderful time we had. Thank you. Thank you.
Okay, bye.